Hi guys, welcome back to the discussion. Kidneys are a perfect example of maintaining balance. Whether it's sodium, potassium, acid-base, water, any slight aberration in the normal values can contribute to cerebral edema, the brain swelling would come in, or like the imbalance of potassium can contribute to heart to stop. So kidneys are like that perfect example of both hard work and balance. And the amount of ultrafiltrate that travels through our kidneys every single day is a mind-boggling 180 liters. Yes, guys. Our kidney tubules are handling 180 liters of ultrafiltrate every single day, out of which 178.5 is reabsorbed, and the rest is obviously the waste, that is urine, and that is what we test and we can pick up diseases in patients. So let's start with one of the very common kidney disease, that is CKD, chronic kidney disease. While I write the leading cause of it, that is diabetic nephropathy, my question to you guys is, tell me what is the best method by which you can calculate the GFR of a patient, and GFR less than how much is called as chronic kidney disease. Obviously, the normal value is 125 ml per minute. So you would have read multiple times that the estimated glomerular filtration rate, if it turns out to be less than 60 for 3 consecutive months in a patient, like the GFR value less than 60 ml per minute, 1.73 meters square of body surface area, and for 3 consecutive months, let me say January, February, March of a particular year, if the estimated GFR is less than this particular value, I will say my patient is having chronic kidney disease. Now, how would I calculate this estimated GFR? So we have an online calculator. In that online calculator, you will have to feed in certain parameters like age of the patient, weight, gender, serum creatinine, cystatin C. Yes, I think the moment I said the word cystatin C, you would have remembered that in the main videos I've taught you, the formula that is used for calculation of GFR is CKD EPI cystatin C formula. Even in the MCQ, inulin clearance word is given. Because I know that in physiology class, they'll say, what is the best method for calculation of GFR? It's inulin clearance there. And if you call up any lab and say, I want to get an inulin clearance there, inulin clearance done, they're going to ask you, doctor, what? What test you want to do? We have never heard about it, because that's only for physiology labs. In reality, how we calculate GFR of a person is CKD EPI cystatin C formula. There are multiple variables here. I'll just say them verbally: age, weight, gender, serum creatinine, race of a person. Because obviously, the Russian people are muscular than us, and muscle mass also decides the value of serum creatinine. And we take one more parameter apart from creatinine, that is cystatin C. This is a product which is produced by all nucleated cells. Now, the number one cause of CKD is diabetic nephropathy. Number one cause of dialysis in India and America is CKD, that is diabetic nephropathy. And the number one cause of kidney transplantation happens to be, again, diabetic nephropathy. Now, the impression that comes in every student's mind is that in CKD, the size of kidney can be shrunken. Yeah, if I'm talking about burnt out kidney due to chronic glomerulonephritis, the kidney size would be shrunken. But in the exam, he has asked, in patient of CKD, patient is having a normal size kidney or an enlarged kidney, which, when we read for the first time, looks a little paradoxical kind of a statement, because the impression is that kidney should be shrunken. So agreed, it is shrunken in chronic glomerulonephritis. But when it comes to HIV associated nephropathy, the kidneys are enlarged. You see, this A is not for autosomal dominant polycystic kidney disease. Autosomal polycystic kidney disease, the kidneys are huge. There's like a super enlargement of the kidney. So I'll handle the topic subsequently. But in ADPKD and ARPKD, understandably, there is a CKD, but those are super enlarged kidneys. They can fill up the entire pelvis of the kidney. At the moment, I'm not talking about autosomal dominant polycystic kidney disease. I'm saying amyloidosis, where you can be having pale, normal to slightly enlarged kidneys. And D is obviously the topic that I mentioned superiorly, that is diabetes, which on long-term basis can cause a diabetic nephropathy. Now, once a person will develop CKD, there is bound to be some hormonal changes in the body as well. So what are the hormones that will be decreasing? So one of the hormones that is produced by our kidneys, vitamin D3, the levels are bound to decrease. Can you tell me which part of our kidney, which part of the kidney tubule is responsible for synthesis of vitamin D3? Your answer will be proximal convoluted tubule. See, proximal convoluted tubule has this enzyme by the name of 1-alpha hydroxylase, which is responsible for formation of that active form of vitamin D, that is 125 dihydroxycholecalciferol. And if the CKD patient comes to us, then vitamin D3 is less, and that will cause a hypocalcemia with hyperphosphatemia. The second hormone which will be critically low is erythropoietin. Where is erythropoietin produced in the kidney? Well, just like you are comfortable, right? Renin is produced by the kidney and it is produced by the JJ apparatus. I asked you where is erythropoietin produced, so your answer would be given as peritubular cells, and the level of this would be less, so therefore there would be a normocytic normochromic anemia. And for treating this normocytic normochromic anemia, they have asked it multiple times in NEET PG in both FMG exam. Darbepoetin, that is recombinant erythropoietin, would be given. The third hormone that is lesser is also beginning with E, that is estrogen, and that is why female patients can be having menstrual abnormalities. So D, E, those are the hormones that would be less. And when it comes to increasing, then the levels of insulin are relatively increased because insulin is excreted by the kidney. So the kidney is damaged, then the insulin levels would be higher. And why are you being taught this is because he will ask you that in a diabetic patient, this is again a NEET PG question, what will be the dose adjustment of insulin? I said insulin is excreted via the kidney. In case the patient's kidneys are damaged, if I give the regular dose of insulin, it has propensity to cause hypoglycemia because it will not be excreted. So I will have to do dose reduction. Dose reduction would be something in the range of about 80%. So the aspect of insulin will come up subsequently once again. But yes, the values of this are increased because it is not getting excreted. Same for FGF23. FGF23 helps in regulation of what levels? Then it is responsible for regulation of phosphate, and PTH, as you know, will be acting on the bone. It is responsible for regulation of calcium. And in all patients of CKD, you will notice by default the report will always be like this. Vitamin D will always be less. The values of calcium therefore will begin to decrease. Because calcium will be less, PTH will be high. That is why all MCQs of secondary hyperparathyroidism answer will be the topic of interest, chronic kidney disease. And well, what will happen to phosphate levels here? Then phosphate will not be excreted. This phosphate will cause calcification of the important blood vessels in the body. Lots of time you will read that patients of CKD have higher incidence of a heart attack. I can give example of Sushma Swaraj ma'am. She was like a leader in BJP one government, one of Ministry of External Affairs. She was a cabinet rank minister. And why I'm giving you that example is because ma'am was a diabetic. She did not take off her health. She went into diabetic nephropathy. She underwent kidney transplantation at Thames Hospital. But in spite of everything, the best medical care provided, ma'am ultimately had a heart attack and she died. I'm telling you this because if a cabinet rank minister who has access to all kind of, when it comes to like cabinet rank minister, there would be ambulance, doctor, everybody available at the drop of a hat, not like an ordinary citizen who would may not be getting medical supplies. So if a cabinet rank minister can have a heart attack due to kidney disease and we are not able to do anything, then you can understand the kind of seriousness that I'm talking about. And all of that is attributed to which ion or which molecule? It is phosphate, which chelates with calcium, gets deposited in the blood vessels, make them hardened. And coronary artery blood vessels hardening can then predispose to atherosclerotic plaques tearing, and therefore heart attack can occur. That is why you can see the next question that they've asked in the paper is, what is the leading cause of death in patients of CKD? Your answer is not to be answered as renal failure, uremia. It is accelerated cardiovascular mortality. Vedri writes in the MCQ CKD, Vedri says what is the leading cause of death due to autosomal dominant polycystic kidney disease. Vedri says what is the leading cause of death with respect to hemodialysis. Any one of these situations that I've written, CKD, ADPKD, hemodialysis, your answer is not uremia, not asterixis, not uremic encephalopathy. They will look very, very tempting. They will deliberately make the question multiple correct options. So a lot of people select not only the cardiac perspective, but even uremic encephalopathy. Well, we can handle that. But the cardiovascular mortality part is like accelerated atherosclerosis is difficult to handle. So this happens to be the number one cause of death. Well, then what should we do? We should go aggressive on blood pressure control. We should go aggressive on statins for these patients. I'm going to describe those drugs before you. I will teach you the important drugs for diabetic nephropathy. But at the moment, target blood pressure is one single intervention that will cause a substantial reduction in mortality. And the danger is not over because there is one more ion in the body that is waiting to strike. It's like multiple enemies. That's why I said kidney is responsible for maintaining balance. If the moment the balance goes away, it's a crazy war out there. Then it's like you are super aggressive with respect to your management, because even if I control the blood pressure, I might be able to reduce the incidence of a heart attack. I have another problem occurring that can affect the heart, hyperkalemia. Hyperkalemia can cause a cardiac arrest in a person. So we'll talk about the treatment of this also, but at the moment I'm dealing with those important questions that you have to remember. What is the predominant electrolyte abnormality in CKD patients? Already explained to you, hyperkalemia. And basically the problem is that the kidneys are not able to excrete hydrogen. They are not able to excrete potassium. Hydrogen is excreted as ammonium ions. Hydrogen is excreted as ammonium ions. So lots of time he may not write the word inability to excrete hydrogen. He may write inability to excrete ammonium, and therefore like metabolic acidosis will appear. The type of metabolic acidosis that can occur in patients of parenchymal disorders of the kidney is high anion gap metabolic acidosis. By default, whenever kidney will be affected, there would be high anion gap metabolic acidosis. Whether he says the word acute kidney injury, chronic kidney injury, acute tubular necrosis, all kidney damages always result in development of high anion gap metabolic acidosis. The only situation where in the topic of kidney would you be getting a normal anion gap metabolic acidosis is renal tubular acidosis. I'll speak about this later also, but at this moment I wanted to remember that RTA. I'll describe the three varieties before you, but this is the only type of like kidney damage where I'll say normal anion gap metabolic acidosis, NAGMA. Every time else, it's always going to be a HAGMA, high anion gap metabolic acidosis. Now, unlikely to develop in patients of CKD. Like what I'm trying to say for the next question is he gave multiple like conditions where he said which of these is unlikely to go into a chronic kidney disease in a patient. Options were like analgesic nephropathy or like a person who's having hypertensive nephrosclerosis. So ultimately like hypertensive nephrosclerosis, analgesic nephropathy, they'll contribute to CKD. But one condition that we'll be discussing subsequently has good chances of recovery. It's usually found in children or teenagers, that is post-streptococcal glomerulonephritis. So among the list of disorders which is least likely to go into chronic kidney disease is PSGN. All other varieties of GN, like RPGN, MPGN, MGN, whatever varieties he will write, they have a higher propensity to go towards CKD. But in PSGN, there's a transient like decrease in the complement level, and usually we get good chances of recovery. Now, as far as the staging of chronic kidney disease is concerned, like the GFR will decrease from 90, 60, 30 like that. So the staging of CKD is based on calculation of the estimated glomerular filtration rate. And the second thing that we'll check will be a urinary protein. Yes, guys. And what is the protein that we'll be checking? Urinary albumin. And when we are taking the spot urine sample of the patient, in that spot urine sample, we will be checking urinary albumin creatinine ratio. So it is UAC. I'll tell you the values also which are to be remembered. But then how do we grade the severity of chronic kidney disease is on a combination of estimated GFR and urinary albumin creatinine ratio. The complications will usually start occurring when patient goes into grade 3 to grade 4. Grade 4 is the threshold. If I say 4 is the threshold at which RRT, that is renal replacement therapy, process must always be initiated. That means that either we should plan for a kidney transplantation, and if a patient does not have financial support, donor, he does not have the resources available for transplantation could be lacking from the hospital side, from the perspective where the person lives, or maybe the person is having all the money but he doesn't have like donor available. So we can plan hemodialysis. So RRT means that either we can do a transplantation or we can do a dialysis. Complications of each one of them would be discussed. If we do not act, the patient will go into grade 5, and that is when uremia manifestations will occur, like uremic pericarditis, uremic encephalopathy, uremic melena. Urea is a toxin. It causes even internal GI bleeding. That's why I said the word melena. And the neurological manifestations that could be occurring in these patients is because it's a toxin. So it could contribute to development or damage to the nerves also. So if he says what is the most common neurological disorder that is seen in patients of chronic kidney disease, that the uremia component can cause damage to peripheral nerves, so peripheral neuropathy can result. And then if he says the person is ending up with seizures, leading cause of seizures in these patients of chronic kidney disease. You see, one is seizures after undergoing a dialysis. That also I'll discuss. But if he just says patient is having seizures, then the problem is that there is a volume expansion. Volume expansion will contribute to hyponatremia in a patient. So what I can mention at the moment is that this person will be having is a hypervolemic hyponatremia. So therefore, the simple English word which we will expect in the MCQs most of the time would be water intoxication. I'll say that again, in patients of damage to the kidney, GFR is less, RAS is activated, so the aldosterone values are super spike elevated. Once aldosterone comes into picture, it will draw more water and it will also draw more salt in the body. So total body, in fact, like TB, if I write, it will, if that tuberculosis impression, so let me write the whole thing, that because of the fact that the RAS system is going into an overdrive in these patients, so total body salt in the body will be increased. At the same time, the amount of total body water, because aldosterone brings both the things now, so total body salt and total body water in the patient will be significantly increased. You can see that I mentioned both of these parameters being substantially increased, including like I put 3+ for water to say that there would be edema. So you could be having periorbital edema. In fact, in kidney disease, the edema first starts from the eyes and then tends to go towards the feet, whereas when in heart failure, the edema first tends to develop around the feet. So lots of time questions of kidney will talk about periorbital edema and pedal edema in that matter of fact. And the technical word that I want to say for this is that because there is extra salt, extra water in the body, so therefore we will say hypervolemic. But because I have put 3 for water and 2 for salt, so I want to say some dilution component also coming. So in these patients, there would be a hypervolemic hyponatremia, and that excess water can contribute to brain swelling. It can contribute to water intoxication. A lot of patients of CKD can come to us with chest pain. The chest pain is because they are having one uremic pericarditis, but they can be having a heart attack also. So how do I differentiate? Because troponin I is anyway elevated because it is not excreted from the kidney. I repeat that again. Trop I values as compared to UM means CKD patient are already elevated. Now, if he complains of chest pain, either it could be due to possibility of MI or it could be a uremic pericarditis. I need to differentiate. So for differentiating, what I will do in the patient is not a single value of troponin I, but we'll go for a serial troponin I. That is, if the troponin I values are showing an increasing trend, that means that the person is having a myocardial infarction, because necrosis will cause more and more myocytes to die. So the values will begin to rise. So like I can do 1 troponin I now, I can repeat that after 6 hours and then after 12 hours. That's like a proof. Treatment, obviously, we will start in the patient with respect to like if he's having features of myocardial infarction. But then what I'm trying to say is that single value will never be reliable because baseline value is more. Why baseline value is more? Because tropa is excreted from the kidney also. I mean, it's a product in the cells, but there's some baseline value in the blood. Now it continuously gets excreted from the kidney. Kidney is damaged. The values are anyway above the baseline. So we need to take multiple values reading before we say that the person is having a documented myocardial infarction. Then there are certain drugs which are never to be used in CKD, that is diclofenac sodium. All of these drugs, because diclofenac sodium, what it will do is it will interfere with the renal prostaglandin production, and prostaglandins play a role in maintenance of GFR. So because the prostaglandin production is lesser, the GFR will decrease and it can trigger, in fact, like acute kidney injury. It is like a AKI on a CKD. Already the person is having CKD. I gave a painkiller to the patient. So there could be a superimposed acute kidney injury occurring in a patient. Then antifungal drugs which are not to be used are amphotericin B and foscarnet. Both of them are known to cause electrolyte imbalances also, that is hypovolemia and hypomagnesemia. Antibiotics that should not be used are aminoglycosides, understandably, and vancomycin. Aminoglycosides, they cause non-oliguric renal failure. I'll teach you the meaning of that. Very interesting term, non-oliguric renal failure. Then are anti-cancer drugs. So I mentioned antibiotics, antifungal, anti-cancer drugs, methotrexate and platins, that is like cisplatin, carboplatin, and cyclosporin. They are drugs never ever to be used in CKD because they can cause further decrease in the kidney function of a patient. Now, I'll teach you a question which is more from pediatrics, but I'll still cover it here. The question said, calculate the estimated GFR of a 3-year-old child with weight of 12 kg and height of about 100 centimeter. Serum creatinine was like 1 milligram. So the formula is for children. It's not the weight that we take into consideration. The weight is a distraction here. It is kappa into height, and then the whole thing is to be divided by whatever is the serum creatinine value of this particular patient. The kappa value is to be taken according to the books as 0.4. So this is a one-step multiplication. 0.4 into 100 divided by 1. You see, if you are doing some fancy rocket science, if you're doing some fancy rocket science in the exam with respect to mathematics, it means that your logic is wrong. Here it's like a one-step multiplication and division by 1. So the answer is 40 ml per minute. This also tells you that serum creatinine of the patient can actually be in a normal range, but still the kidney is damaged. Obviously, like serum creatinine of 1 was looking fairly decent now. Like first time when you read, normally in adult serum creatinine is range of 0.8 to 1.2. Children can be a little lesser, but then 1 doesn't look like a very, if suppose I said to you serum creatinine creatinine is 4, 5, I mean, it sends an alarm bell. Okay, man, kidneys damaged. Serum creatinine of 1 looks like pretty decent value. And like you saw that it's a distraction. The GFR of the patient is substantially low here, that is about 40 ml per minute. So the message here is that don't rely only on serum creatinine. We have like these calculators available for calculating the estimated GFR. And if I zoom out of this slide, this is like critical data, guys, which are facts to be remembered, and all are interlinked to each other. Like I said, phosphate is super elevated, calcification of blood vessels. That is why dialysis, polycystic kidney, CKD, you get accelerated cardiovascular mortality. Then you insult with hyperkalemia. Question for you guys. Tell me a novel potassium binding agent. Tell me a new novel potassium binding agent. I'll say it verbally at the moment. Just waiting for you. 3 seconds, guys. Yes, I think you read pharmacology. And I know it's a recorded class. The drugs are like zirconate, right? Sodium zirconate, sodium polystyrene sulfonate. So a lot of interesting data is going to come up subsequently. I'm not only going to talk about calcium gluconate and hyperkalemia. I agree that's the drug of choice, but we'll talk about novel NOVEL, novel potassium binding agent. At the moment, no need to note it down, guys. Aage jagah hai in the notes. We will talk about it. I just wanted to give you a heads up with respect to like what are the the interesting things that are gonna come. All those kidney diseases that end with GN, like RPGN, MGN, MPGN, they ultimately cause a damage to the kidney, that is CGN. But one like stands out as not causing a CKD, that is post-streptococcal glomerulonephritis. Now we will talk about the grades of CKD as well as the albuminuria values. That is like we'll talk about urine. In the urine spot sample, I will be checking for the albumin creatinine ratio. So let's work out this data with respect to like what are the paramount things to be remembered. If I say the word mild CKD, that means GFR will be less than 90 in the range of 60 to 80. Why this is important to be known is like the query that I get from a lot of students is, sir, you said CKDs are defined as GFR less than 60. So why are you now telling us a value more than 60? I want early diagnosis, na? Why should I start at 60? This classification deliberately has been asked in the exam, not because they want to harass you with the numbers, but they want you to realize that if the threshold is at 60, why should we wait for 60 damage to occur and then say, oh man, your kidneys are damaged? We can identify early also. So that is like 60 to 89, just decrease by 30 points initially, and then decrease by 15 points, and you'll have another value that is 15 to 29. This is where like most complications will start occurring. This is the time when you will be having like metabolic acidosis, hyperkalemia, calcium will be low, phosphate will be deranged. These are the common derangements. Hyperkalemic acidosis, hypocalcemia, and hyperphosphatemia would start happening. And because like these derangements will worsen as we go into stage ESRD, end stage renal disease, this is when uremia features will start occurring in a patient. In fact, at this moment, I also want to bring a very interesting term to your notice. When we write the word end-stage renal disease on the case file, then patients' relatives feel very bad about it. The doctor, you are so heartless. You wrote the word end-stage renal disease on my dad's file. He was crying the whole night. So, I mean, you don't have any empathy. You don't feel like anything. I mean, you don't have any emotions in you, doctor. So this patient started a social media campaign. Imagine the patients and their relatives started a social media campaign saying doctors are so heartless that they write the word end stage renal disease. And therefore, like the current edition of Harrison says that now we should not use the word end stage renal disease because of the negative vibes it creates. And the term that we should now be using is the word renal failure. Sounds funny, right? I mean, on one hand, we are writing the word end-stage renal disease. Now he says, don't write the word end-stage renal disease, write the word renal failure. So I hope it's clear to you that in the exam, if he says, what is the definition of the word renal failure? One is acute renal failure, chronic renal failure, things are different. If he just says the word renal failure, it is more sinister, more dangerous, then your answer is going to be estimated GFR of the patient less than 15. And next, just to see you got me or not, I'll mention a question which was asked in FMG exam. What is best to differentiate acute kidney injury and chronic kidney disease? Well, a lot of guys here casually answered it as size of the kidney. In the actual exam, what I think I've been able to explain to you is that size can be normal in diabetic nephropathy or even increased in diabetic nephropathy. So size is not the criteria. See, blood urea nitrogen can be deranged, creatinine can be deranged in any patient having kidney damage. The answer here is not the size of the kidneys. It is what we have been discussing. Calculate the eGFR, that is creatinine clearance, and urinary albumin? The answer for this is option number A. What is best to differentiate acute kidney injury and chronic kidney disease? It is creatinine clearance and urine albumin. Urine albumin will not be present in acute kidney injury. So the definition of AKI is obviously pending, but at the moment our focus is to remember all these grades of CKD. In fact, in recent NEET PG, he asked G3A, and therefore it's important to remember these values. When I say G1, G2, obviously I'm not talking about Gravida 1, Gravida 2, I'm talking about grades of CKD. So if the GFAR of a person is more than 90 ml per minute, 1.73 meters square body surface area, it is G1. Now, decrease it by 30 points. Decrease it by 30 points and this mathematical value will become 60 to 89 ml per minute. Now, when you decrease, now in this table, the decremental value to be taken all through is 15 ml. Don't decrease now by 30 points. Only first time 30 point, then 15, 15, 15 decrement only. So the 15 point decrement would mean the G3A, which was asked in the exam, is 40 to 59 ml per minute. And if I look at mathematics here, G3B will be 30 to 44. Now, a lot of my students who are like super intelligent boys and girls, they just got confused. Ki, sir, in the last, I could not even remember that what was G3A and G3B. And like, you know, the 15 decrement is fine. But like if somebody is in a pressure in the exam, things can go wrong. So yeah, some people messed up and answer is 30 to 44 also. The correct one is 45 to 59. Value based question was asked. So fine, we have to be aware of the decrements of 15 points. And now we reach into G4, where I taught you that we have to go for renal replacement therapy, and G5 is where I said the word renal failure. This is where uremic features will occur. Uremic features can be like uremic pericarditis. It can cause chest pain. It can cause hemopericardium. Yes, guys, urea is a toxin, so it can cause hemopericardium and cause a cardiac tamponade in a patient. That is why in the earlier part of the discussion, I said the technical word for this now is not end-stage renal disease. It is renal failure. G4 is to be remembered as the stage where the decision of RRT has to be taken. Either we go for transplantation. If transplantation is not possible, whatever be the logistics, then it is kidney transplantation, for which we need to create a fistula in the non-dominant hand of the patient. That fistula will also take some time to harvest. So I need time to, create a fistula. I need time to harvest the fistula. So I'll talk about that Seminobristia fistula for RRT subsequently. And as I've explained to you, that CKD starts at a value less than 60, that is G3A, but we don't wait for the values to fall to this critically low values. We start identifying at a value of 90 only. Minimum that I expect you to remember next 15 seconds is 90, 60, 30 and 15. For 90, it is G1, 60 CKD, 30 is the value or lesser when we plan RRT, and 15 is where you get the word renal failure / end-stage renal disease and uremia. Apart from this, we will also talk about proteins in the urine of a patient, that is A1, A2, A3. A question to you guys, do you have proteins present in urine of a normal person? Just quickly nod your head. I obviously can't see you, but just nod your head. Do you have proteins present in urine of a normal person? If yes, then how much? If no, then it's okay. Yes, guys, we do have proteins in the urine of a person, no? How much is the protein present in the urine of a normal person? Then your answer would be less than 150 milligram per day. Yes, guys, our kidneys are not able to prevent all the proteins from coming because we have filtration slits in the kidney, so some protein is bound to come. Now this 150 I'll divide into two, that is glomerular and tubular proteinuria. When I talk about glomerular proteinuria, the protein that will be able to filter across through the filtration slits in the glomerulus is albumin. Though the basement membrane of the kidney is negatively charged and negative charges repel each other, but still some albumin is still able to come. The amount of albumin present in the urine of a normal person is less than 30 milligram per day. In contrast, some of the proteins can be coming from the tubules. This protein that is coming from the tubules is also mentioned in the book as Tamm-Horsfall protein. This Tamm-Horsfall protein is the one which is responsible for formation of casts. In the urine of a normal person, we have hyaline cast. So that hyaline cast is composed of Tamm-Horsfall protein. That would be the remaining 120 milligrams per day. So the message is that we are having like proteins coming from the glomerulus as well as from the tubules. In fact, if he wants to get a bit into physiology, he can also give you a question saying that suppose this is the loop of Henle. It has a descending limb, ascending limb. So like which part of the loop of Henle will be synthesizing Tamm-Horsfall protein? Then your answer is it is the ascending limb. Like you can see, I have here shown the ascending limb of the loop of Henle. Just I'll use a short form there. Ascending limb of loop of Henle is LOH's loop of Henle is responsible for synthesis of TAM protein, which is usually excreted as hyaline cast. So at the moment, the message is we do have proteins present in urine of a normal person, and if diabetes will cause damage to the glomerulus, so I'll just put a line here to say that if the glomerulus is damaged, then the proteinuria, that is albuminuria, will be there. So as far as A1, A2 and A3 are concerned, for this we don't need to go for a timed 24-hour urine collection. The timed 24-hour urine collection is messy, it can be unhygienic, and more importantly, like patients may undercollect or overcollect urine practically. So the best thing is wait, just take a spot sample. In the spot sample, if the amount of protein present is less than, just focus on the words there, if the value there is less than 30 milligram, but in the denominator now it is not per day. In the denominator, it will be per gram of urinary creatinine. That is what I was present in the table, in the printout, in the handout also. But I am trying to do this mathematical practice with you, that in the spot sample, in the denominator, it is not like per day, it is per gram of urinary creatinine that we are talking about. If the value increases to between 30 to 300, that means the damage has already been done. This is what we read as microalbuminuria, with the denominator being per gram of urinary creatinine. So I'll just use a short form there, that is CR for creatinine. All the time saves me a bit of hassle in writing. And A3 values would be more than 300 milligram per gram of urinary creatinine. I'll just move up my slide to show you the same thing that I had mentioned earlier. And lots of time in the MCQs, he may not write it as like 30 milligram per gram of urinary creatinine. It may be written as milligram per millimoles. So you can see that zero will become lesser. Like you can see it was 30, so zero remove ho gaya. Similarly, 30 to 300, now you can see the value is 3 to 30, and then the value is more than 30. Why I'm telling you this is because it depends on the units that the value would be present. You see, this mathematical value I said is the time when damage has already occurred. This is microalbuminuria that I was talking about, and you can see that in the MCQ, because he knows that you will pick up that value, he may deliberately write it as 32. Instead of writing 30 to 300, he may write it as 3, reduce 110 from both, 3 to 30 milligram, but in the denominator it is micromoles. Now mathematics, man, this may be like wrongly answered by you as normal, whereas this is not normal, this is microalbuminuria. I'll say the mathematics again, 30 to 300 milligram per gram of urinary creatinine. Remove 110 there, 3 to 30 milligram per micromole could also be described in the question. And microalbuminuria indicates, the word microalbuminuria itself is a test that tells you that in your patient there could be a possibility of like damage, and those damage could result in, like, I'll just make the slide relatively bigger. Microalbuminuria increases the risk of cardiovascular mortality in the patient. CV mortality is increased. All through the discussion, we are talking about uremia, and like the cause of death would be answered as CV mortality. This itself is a question, guys, that what test in a kidney patient tells you that there is increased cardiovascular mortality? Your answer is urinary albumin creatinine ratio, UAC, or it might be written as UPCR, urinary protein creatinine ratio. Either of the two terminologies, the message is test that predicts cardiovascular mortality in kidney damages, urinary albumin creatinine ratio, which can be checked in the spot urine sample. And this practice that I've done might look a little overbearing to you at the moment, but believe me, if you did not pay attention at this point of time, pause the video, go back and do this mathematics with me once in your life at least. Unless and until you do this, because when these value-based questions come now, people are in a dilemma. So it's always a good idea to practice this right here with the teacher only. It becomes relatively easier. And like I said, glomerulus has a negative charge, like charges repel each other, but that's not absolute. Like some protein will always be coming. The magnitude can obviously vary. Now we will study regarding what will we do in a patient who's having chronic kidney disease. The mnemonic for remembering this is ABCDE for management of CKD. A would mean that we have to keep the glycosylated hemoglobin of the patient well under control now. The level of glycemic control I want to achieve is a value of less than 7%. So in a person who's gone into CKD, I have to anyway stop metformin. I've already explained to you in the diabetes section also, and I'm repeating once again that stop metformin if the estimated glomerular filtration rate of the patient is less than 30 ml per minute. If I continued some medical negligence on my part, and it can trigger lactic acidosis. So now what will I do if I stop metformin? One is I can start the patient on gliflozins. That also I'll talk about. But because like the damage is fairly extensive and the HbA1c could be like 12, 13, 14. So rather I would like to first manage the patient by starting insulin. Later I can add gliflozins. When I start insulin at the moment for aggressive control, he will ask me that what should I do to the insulin dose, because I explained to you that insulin is excreted via the kidney. This was a pharmacology / medicine NEET PG question, that what should be done for the dose of insulin. Then it is like to be given at 80% of the calculated dose, because if I give the regular dose, it will not be excreted. It will cause hypoglycemia in the patient. So A is HbA1c control. Then is B would stand for like blood pressure control. This blood pressure control value I've already told you, that would be value of less than 130/80. How will I be achieving it? I'll be achieving it by starting my patient on ACE inhibitors. One of the big side effects of ACE inhibitors, however, is hyperkalemia. So if he specifically mentions that a person of chronic kidney disease, let me just write down the situation here. A patient of chronic kidney disease is having hypertension and his serum potassium is like almost 6.5, then it's not a good idea to continue with ACE inhibitors, because I could be having is a deterioration in my patient, because ACE inhibitors also cause hyperkalemia and CKD also causes hyperkalemia. So I don't want a problem of cardiac arrest. Initially, what I can do is I can give more Lasix to this patient or diuretics like thiazides to decrease the potassium. I can also be using potassium chelators in this patient, but then that would be a risky maneuver. So what he recommends is that at this moment, we should give calcium channel blocker to the patient. That CCB, the advantage will be that you will not have the problem with respect to hyperkalemia. Additional drug that can be used, because lots of time ankle edema is the side effect of CCB. So if I modify this question further, this question that I'm saying is purely from the INISET perspective. He gave a question of CKD, hypertension, hyperkalemia, also added pedal edema. Now, if pedal edema is present, then answer will not even be CKD. Then the answer will be the drug that are right after this, that is a alpha-1 blocker, that is prazosin. So to take care of the fact that if he just gives you a situation where CKD, hypertension, hyperkalemia is given, your answer is calcium channel blocker, amlodipine. If he specifies ankle edema is pre-existing, because kidney damage will cause edema not due to volume expansion, then my answer would be not CCB. I'll go the next step, that is alpha-1 blocker, prazosin would be used for the patient. Then is I need to keep LDL cholesterol under LDL cholesterol control has to be obtained. The target LDL that I need to obtain in this patient, like C stands for keeping the value of LDL cholesterol under check. C is cholesterol values to be under check. What should be the target LDL? Then in a diabetic patient, I should be keeping it at a value less than 70 by giving statins to the patient. If a person has already had a cardiac event, like a diabetic patient has already had a cardiac event, that is atherosclerotic cardiovascular disease is given in the question. What I mean by the word ASCVD is that he has already had a MI, or there is stents in the coronary artery, or there's a coronary artery bypass grafting, and he says what is the target LDL to be obtained, then your answer is less than 55. So I've described two data to you. One is going to be like high risk and second is extremely high risk patient. For the extremely high risk patient, obviously the dose of statins would even be more escalated, but then the bottom line is I need to still give to the patient HMG coenzyme A reductase inhibitor. Question for you guys from pharmacology is HMG coenzyme A reductase inhibitor, that is statin that you're giving, high dose statin that you're giving, it will act by inhibit the production of what raw material which is responsible for synthesis of LDL cholesterol. Enzyme name is okay, HMG coenzyme A reductase inhibitor. He said statins that you're giving for this patient, whether it is a high risk patient diabetic or it's like a diabetic already with atherosclerotic cardiovascular disease, what medicine would be given? I mean, how will this drug work is that it will inhibit the raw material for synthesis of the bad cholesterol, that is LDL, and that is mevalonate that would be used. So A is HbA1c, B is blood pressure control, C is the LDL cholesterol values, D is for handling the values of low vitamin D3, because vitamin D3 is less. This means that even calcium will be less, and due to less calcium, these patients can be having pathological fractures of the bones also. Patients of CKD can have bone pain, they can have pathological fractures also. Now, because of the fact that calcium is less, the PTH values in the body will begin to rise. There would be a secondary hyperparathyroidism. This itself is a question, what is the number one cause of primary hyperparathyroidism? Parathyroid adenoma, discussed in the endocrine section. Secondary hyperthyroidism is the topic that I'm discussing at the moment, CKD. Because PTH is more, it will remove calcium from the bones. It will remove calcium from the bones. And when it will remove calcium from the bones, it will cause a bone weakening. And the manifestation that is developing is called as osteitis cystica fibrosa. If you just focus on the word that I've written here, osteitis cystica fibrosa, it means that it's like PTH is removing calcium from the bone. So it's literally punching holes in the bone. And that is why the bone is weak and it can break also. And in fact, in osteitis cystica fibrosa, there's also a possibility that they can be bleeding in these cysts. And because of the bleeding, like hemoglobin will degenerate to produce hemosiderin, which is brown in color. So the pathologist would have said the word brown tumor is a misnomer. Brown tumor is a misnomer seen in patients of hyperparathyroidism, both primary and secondary variety, and it causes, this explains the fact that why these patients would be having bone pain, and this also explains why these patients would be having anemia, because the normoblasts in the bone marrow will not be able to function properly. Osteitis cystica fibrosa you get in primary as well as secondary hyperparathyroidism, and these patients would be having two implications of it. One could be bone pain, pathological fractures. Second, bone marrow is having this like bleed and cysts present. That means that even hematopoiesis will be hampered. So like there are multiple reasons why like anemia will occur, but one of the reasons is even osteitis cystica fibrosa, because bone marrow gets involved in this person. Now in these patients, the values of phosphate will begin to spike. Why? Because it will not be excreted, and because phosphate will chelate with calcium to form even kidney stones that will cause double insult. So they've asked in the paper that what will you do first in these patients? So don't start with vitamin D3. Don't start with vitamin D3. Yes, we will give vitamin D3, but the first thing to be done in this patient is give a phosphate binder. And what is the name of the phosphate binder? Must know fact for you, that would be semaglutide. The question would be, what is the first line management for a person having CKD with hyperphosphatemia and like secondary hyperparathyroidism? Then because phosphate is elevated, this can cause accelerated cardiovascular mortality. I want to give a phosphate binder to the patient by the name of semaglutide. Once I've given semaglutide to the patient, what will semaglutide do? It is a phosphate binder. It will bind to phosphate. So, I mean, my problem is half solved. But now what I will do is I will give a drug that will inhibit PTH production. So what is the drug that inhibits PTH release from the, like the parathyroid glands are releasing more PTH because calcium stimulus is less, but I will be giving a calcimimetic drug. It will behave like calcium in the blood. So the glands, PTH, parathyroid glands will be fooled to think that, oh, now calcium is normalizing, and they will like decrease the stimulus for PTH release. The mechanism of action of the drug that you have to remember. See, you, all of you have done pharma. But the moment I would have said HMG coenzyme reductase inhibitor inhibits production of what? Right, that mevalonate word might, you know, if you remembered it, great, but most people miss it in a live class. So like that word has to be remembered. And similarly, cinacalcet is a calcimimetic drug. That's what pharma people will say. But then what is the calcimimetic drug doing? It's fooling the parathyroid gland into believing everything is okay. So it will remove the stimulus for PTH release. So the mechanism of action is inhibition of PTH release, because PTH release is the problem that is causing weakness and is causing, it's causing bone weakness and can cause pathological fractures. Then additional aspect, which is an MCQ, is that if the person is taking only vitamin D and calcium, then the stimulus for release of PTH would be gone, and PTH, if it is less, then the bone turnover tends to become less. This is called as adynamic bone disease. So just need to remember that in patients of CKD, if you give only vitamin D and calcium to the patient, you cause a decreased bone turnover. It's like a iatrogenic condition. This condition that I'm describing is a physician-induced condition that he first did not tackle the hyperphosphatemia and the hyper PTH state. First tackle hyperphosphatemia, then tackle hyperparathyroidism. Subsequently, give calcium and vitamin D to the patient. If you handle only calcium and vitamin D, then it causes a decrease in the bone turnover. So this is like an iatrogenic bone disease. If bone turnover is less, that again, it can again increase the risk of pathological fractures in a patient. So this is the iatrogenic induced condition where like the algorithm for management was not managed well. The D component is, I would rate it as one of the most important part with respect to CKD, and then is the E component. Both of them have been asked in NEET PG 2025, 2026. I mean, like I can say like this, that irrespective of the names of years that I say, D and E component of CKD is the most important part of this slide, A, B, C, D, PK, right? The E component is that erythropoietin is less, so I need to give darbepoetin to the patient. But the question had a trick. The trick was he had also mentioned that this person is having a microcytic hypochromic anemia. In fact, like in some questions he mentioned even like I think some students recall said, sir, it was normocytic normochromic. Okay, even in iron deficiency, initially normocytic normochromic can be present. My point is, if you give darbepoetin directly, then what will happen is that the cells that will be formed will not be having enough iron in the body. So he must write in the question, iron levels are replete. If iron levels are normal, you answer darbepoetin, koi tension here. If he says what is the drug of choice for anemia seen in chronic disease, drug of choice is darbepoetin. But if he says what is first to be given to the patient, then answer would be given by you as iron supplementation. This can be obviously like I can give iron supplementation IV in the patient. Oral, because again oral iron causes constipation, diarrhea, GI disturbances, even vomiting in some patients, and CKD patients already have like multiple health problems. So I can give parenteral iron to the patient. But the learning point is, if in any patient of CKD, you notice that he has mentioned that there is an anemia present, unless and until he says the word treatment or choice for anemia related to chronic disease and CKD patient is, then your answer is darbepoetin. But if he says first line, then the answer is iron supplementation. We can be giving iron supplementation orally to the patient. We can be giving it intravenously to the patient. As far as causes of CKD are present, obviously there is erythropoietin deficiency, but there's a concomitant iron deficiency because CKD patients don't eat well. Urea causes them to have that pukish sensation all the time. They don't feel like eating. If you've seen CKD patients, they have catabolism. They lose so much of weight. They become so unhealthy. The unhealthy look on their face can be easily identified. And because the person is not eating food well, so there is bound to be iron deficiency anemia. And then osteitis cystica fibrosa will also contribute to development of damage to the bone marrow. And as a result of that, the normoblastic production will be reduced. Now we come to the PK component here, which is as important as the superior information that I mentioned. So the data to be remembered is, because phosphate will be elevated by default in all patients of AKI and CKD. So we should be starting the patient on like a chelator for phosphate. This phosphate binder that I'm talking about has been discussed earlier also, that is by the name of Sivalimer. That would be started. And then like I'll use the same font and the same color for uniformity. I said phosphate will bind to calcium, will cause calcification of important arteries. CABG may not be possible after that. So what I need to give is a binder that would help me in managing this patient. The word Sivalimer came up in the discussion a little earlier also. If I just move up, you can see the word there. And then the second molecule, why I went into this again, you will be wondering, sir, ye to repetition ho gaya. So bhai, repetition is important for remembering. And now my question to you is, tell me one more drug that can be given for patients of hyperphosphatemia. That is a phosphate binder, and the name is lanthanum carbonate. So there are two phosphate binders that you need to remember for today. One is Sivalimer and the second is lanthanum carbonate. We can use one more molecule here, which is by the name of calcium acetate, not calcium carbonate, but calcium acetate. So I told you three phosphate binders at the moment, and that's for the management of hyperphosphatemia. And now I will talk about the K component in the medical management of CKD, that is hyperkalemia. Because potassium is elevated here, if he says, how would you manage the patient? Then don't answer calcium gluconate. I'm talking about chronic hyperkalemia in a patient. I'm not talking about like calcium gluconate, life-threatening hyperkalemia. Potassium is 6, 5.5, 5.8. I want to decrease it back to normal. So to bring it back to normal, I will be having to give to the patient potassium chelators. These are novel potassium agents, novel potassium binding agents that would be given. That is like one is by the name of Patiromer, or another one that I can mention is sodium zirconate, Patiromer, sodium zirconate, sodium polystyrene sulfonate. Three important names here. It might sound a little overwhelming at the moment, but you need to get used to the data. That is sodium, like this sodium polystyrene sulfonate is an old molecule. It used to be used when I was a student. It's still used as of now. I'm just mentioning the name, the brand name to make you more comfortable. This could be given orally or as an enema by the name of K-bind. This molecule is not like as famous as it used to be earlier because of the side effect that can be seen if the enema of this is given, that is colonic necrosis in a patient. So if they ask you what is the drug that would be used, your answer would be Patiromer. Now we will invest 30 seconds into remembering ABCD PK for the drug component that I mentioned. So let's do it quickly. A is get the HbA1c under control. So you give insulin to the patient. B is blood pressure control. So use ACE inhibitor. For the cholesterol component, use statins. D part was a little tricky. First treat hyperphosphatemia, then subsequently provide cinacalcet to the patient. In E part, like I said, don't straight away answer erythropoietin. First give iron to the patient, then erythropoietin. For phosphate elevation, already told you sevalimer and lalethum carbonate. And for hyperkalemia, chronic one, the answer would be given as patyromar or sodium zirconate. I hope it took me maybe a minute or so, but like the way I said it, it should be totally ingrained in your mind. Whenever they will ask the topic of CKD, this slide is the one that should always flash in your mind. This is a must-know slide for today, guys, from the CKD component that I'm currently explaining to you. That is the medical management that we are discussing. We'll talk about renal replacement therapy also. Let's do a question here. A patient of rheumatoid arthritis is on painkillers for 10 years. BP is elevated. So somebody is taking painkillers. That means the person would have taken like lots of time. These combination painkillers are available. Most of them are like over the counter. Patient will not even know the brand name, or even if they know the brand name, like they'll be saying that, I just went to some chemist shop and he told me to take these painkillers. Rheumatoid arthritis causes joint pain. So it's a lady taking painkillers and there's analgesic nephropathy that is occurring. How do I know it's a nephropathy? BP is elevated. Now somebody is taking painkillers and then there's a CT scan where you can see calcification in the kidney. What you can see in these patients is development of papillary calcification. Both the kidneys of the patient are exhibiting. This is a repeat question, guys, so it would be relatively easy. You can notice papillary calcifications in both kidney parenchyma, and because kidney is damaged and the painkillers have been taken, so both can be related to identify the presentation. And there's a high renin hypertension. I mean, whenever kidney is damaged, the RAS system is activated due to low GFR and therefore BP is elevated. Yes, guys, I think you would have guessed the answer by this point of time. It's obviously not tubular necrosis. And NSAID-induced nephropathy basically causes acute kidney injury. Acute interstitial nephritis is how it causes acute kidney injury. So the answer here is simple: chronic kidney disease. A lot of these painkillers that are available, they may be having this extra, like obviously diclofenac sodium can be present, aceclofenac, diclofenac are present, but there's another one by the name of phenacetin, which is now not used, but sometimes may be available in these combination medicines, OTCs that are available. And the combination of like aceclofenac, phenacetin, they are known to cause development of papillary calcification and analgesic nephropathy, which is CKD manifestation. This question was basically given to test your English, in fact, more than medical knowledge, because NSAID-induced nephropathy like diclofenac can contribute to AKI, and like painkillers on long-term basis can cause acute interstitial nephritis. A few more facts into diabetic nephropathy before I move on to renal replacement therapy. So 2 slides are given here, very characteristic one. If the question says what is the most common histopathological finding in diabetic nephropathy, then the slide that you can see here is having a substantial, like I can say, reduction in the Bowman space. The Bowman space is hardly visible. There's a uniform pink presentation in the entire glomerulus. So the word that will be used here for this shrunken, smaller glomerulus is diffuse glomerulosclerosis. This is the most common histopathological finding. Now, if I scroll to the image on the right hand side, you can notice that characteristic histopathological finding of this case that's called as nodular glomerulosclerosis. This slide I've introduced even in the rheumat section in comparison with lupus nephritis. This characteristic histopathology finding is to be called as Kimmelstein-Wilson change. And while I'm writing it, I want to bring to your attention that all of this is purely academic. In real clinical practice, nobody's gonna be doing a kidney biopsy for diagnosis of diabetic nephropathy. So while I write the names here like Kimmelstein-Wilson change, or while I write the word nodular glomerulosclerosis, I have a question for you. What test would you be writing to a patient of diabetes? He has been suffering from type 2 diabetes for, let me say, previous 10 years, 15 years. And today when he has come to you, he says, sir, I just read an article on the internet that diabetes can harm the kidneys. So can you tell me a test by which I can know that my kidneys are damaged? So the test that I'll be writing for this particular guy to identify diabetic nephropathy would be a urinary albumin creatinine ratio. I will tell him to go to the lab. There he has to give in a spot sample. And the spot sample, we will be checking for the urinary albumin creatinine ratio, that is UAC. If the report comes as follows, that is 30 to 300 milligram, of albumin present per gram of urinary creatinine. I've already explained to you this, that if it's gonna be those micro units present, then it becomes 3 to 30. But the standard data is like microalbuminuria 30 to 300 milligram per gram of urinary creatinine. So I tell the patient, sir, your kidneys are damaged. He's laughing on me. He says, sir, are you serious? You tell me, I'm sitting in front of you. I got my KFT done. It was, let me say, 1.2. That's upper limit of normal. Na? He says from his mobile phone, like this guy, educated one, he says, last Diwali, in my society, in my residential campus, there was a health camp organized by Lal Path Lab or Ranbaxy. And I got my complimentary KFT done on a Diwali Mela. My KFT is 1.2. It's normal. And you tell me my kidney is damaged, doctor. Are you trying to scam me? I said, no, sir, your KFT is normal. That's okay. Because creatinine takes a very long time to rise. Creatinine is a specific test. It is not a sensitive test. Sensitive means early diagnosis. So he says, you mean to say creatinine is not good enough? I said, yeah, that's why I wrote you a test which is used for early diagnosis. That is a urinary albumin creatinine ratio. If you read this kind of report, it means the kidneys are already damaged. Before you write, what will you do for these patients? The earliest feature of diabetic nephropathy should be answered as hyperfiltration. Yes, guys, the GFR in these patients could be actually more than 125. When I describe like this, the query is like, what? You are telling me, doctor, that there is a glomerulosclerosis and then there is an increase of GFR. Sclerosis should cause a GFR to decrease. Sounds very paradoxical. No, sclerosis means GFR should be lesser and I'm saying GFR is more. Guys, in early phase of diabetic nephropathy, what happens is, there's an afferent arteriole going in the kidney, there's an efferent arteriole. The efferent constricts. Afferent is sending blood inside, but efferent is constricted, so the filtration pressure in the glomerulus will rise, and due to higher filtration gradient, GFR can be more than normal. Yes, guys, looks very peculiar in patients of CKD initially because RAS gets activated. GFR is ultimately like kidney is getting affected. So the damage to the kidney, the RAS activation causes that efferent arteriole to constrict. And that constriction of efferent arteriole, imagine like there's a tube and the distal part is squeezed by you. So proximally the pressure will rise now because afferent arteriole sends blood into the glomerulus. So the pressure in the glomerulus will rise. The higher pressure will cause a hyperfiltration and GFR value can be more than 125. Later on it will decrease, agreed, but he's asking you early. So now what will you do in the patient is that you can dilate that efferent arteriole by giving ACE inhibitor. Yes, guys, when we give ACE inhibitors, what they do is that they dilate that efferent arteriole and the filtration gradient in the glomerulus, the filtration pressure will reduce. So the damage to basement membrane will also reduce. No, because higher pressure will cause more damage to the basement membrane, will cause more protein to come in the urine of the patient. So I have to start this patient on low dose ACE inhibitor. The patient, being an educated one, says, sir, this medicine is for hypertension. I'm not hypertensive. Why are you giving me ACE inhibitor? I said, I know that this medicine is for hypertension, but I am not gonna give you for control of hypertension. This is low dose ACE inhibitor because studies have shown that you can slow the progression of damage in the kidney. The next thing that I'll do is based on GFR, I'll plan to stop metformin. Now, when I stop metformin in the patient, then one option for me would be that if I stop metformin, I have to migrate to insulin. But when I will introduce the insulin molecule to the patient, because it is the injection, patient will say a big no. Most Indian patients, even if HbA1c 11, 12, to hell with it, I am not going to take insulin. So if a person is going to refuse, which is a very practical problem, you'll say, okay, not a problem. We can start you on gliflozins, that is SGLT2 inhibitors, which have a cardiorenal benefit. So you can start the patient on like EMPA. You can start the patient on canagliflozin, empagliflozin. Like most of the time, EMPA is used like empagliflozin, which can be used even in GFR as low as up to 20 ml per minute. So EMPA would be started, gliflozins would be started. Gliflozins have a very significant cardiorenal benefit. I've spoken about this drug even in my cardiology discussion, but in case you are coming directly to this video, I want to say that this drug is also used in management of heart failure patients, in non-diabetic patients. Yes, guys, this drug was developed for type 1, is being used in type 2, and is also being used in management of heart failure because it causes salt loss from the body, which is beneficial. So ACE inhibitors, gliflozin, and Finrenon, that would be given because there is a RAS elevation or RAS activation causes more aldosterone. That more aldosterone would mean that I need to give a aldosterone antagonist to the patient also, that is Finrenon. I can be using spironolactone, eplerenone, Finrenon. They've asked this also from pharmacological perspective, that which mineralocorticoid, they'll use a short form, mineralocorticoid receptor antagonist. MRA is mineralocorticoid receptor antagonist, is best suited for CKD patient, then it is Finrenon. Just like in the liver topic, we focus on eplerenone, right? In contrast to spironolactone, here it is Finrenon, which is to be remembered. So these are the drugs which are recommended to slow down the damage to the kidney. And obviously, like if a person is not gonna do it, then he will require a transplantation. Transplantation can add 15 years to life of a diabetic. Transplantation can increase the lifespan of a patient by as much as like almost 15 years. So this is the initial approach that I'll be using in a patient. And then based on the estimated GFR in this patient, if the eGFR of the patient is turning out to be less than 30 ml per minute, we will also be planning a RRT for this guy, that is renal replacement therapy. In renal replacement therapy, one strategy we can be using is allogenic kidney transplantation, where we need to do a proper matching in a patient. Nowadays, I can say that blood group matching is not mandatory, but HLA matching is mandatory to decrease the chances of rejection. Or the second approach I can be doing in this patient is plan a hemodialysis. For hemodialysis, the data at the moment is that one session of hemodialysis will take approximately 4 hours, and hemodialysis needs to be done at least 3 times per week. So the person will have to spend approximately 12 hours attached to a machine to get the blood cleaned of the toxins which are present. And either of the two can be used as a strategy, but between the two, if they ask you, then your first single best answer would be that I'll do a allogenic kidney transplantation in this patient. And if person does not have resources, then we can plan a hemodialysis. Preferred modalities, kidney transplantation, most common used is hemodialysis. And when we are doing the hemodialysis, then most common complication of hemodialysis is also asked. The most common complication is hypotension. That's because you are losing water from the body. Dialysis patient undergoing dialysis would be having expanded volume state. They're having a higher RAS state. So therefore, there's expansion of the plasma volume. So when you lose water, there can be hypotension. And then this hypotension is accentuated by one component which is present in the dialysate fluid, which is by the name of acetate, which tends to cause vasodilatory activities. And then cooling the dialysate helps to reduce this complication. That's just a palliative step that I can say, but yeah, hypotension is a known complication. Now, if I change the question and say, what is the most common complication of recurrent hemodialysis? You can see one word will change the entire perspective here. If I miss this word, I lose the precious question. Most common complication of hemodialysis, fine, hypotension. If he changes that to recurrent hemodialysis, then you will say that, okay, I'll be planning in this person, exerted atherosclerosis is there. So he might have a heart attack in future. And even if I'm doing hemodialysis on recurrent basis, I need to create a permanent site from where the dialysis would be done, mostly from the non-dominant hand of a person. So, the blood vessels that would be used here would be two, that is the radial artery and the cephalic vein. This communication that we create between the two is what is called as seminobrestia fistula. The basic advantage of doing this is arterialization of the vein, because you will get a continuous pressure gradient. If you take out blood from a vein will collapse. Now, if you've ever taken a sample 20 cc and you put needle in a vein, when you try to remove the blood, the vein collapses. But in this particular case, what you'll notice is that because artery is connected to the vein, it will reduce the chances of thrombophlebitis of the vein, and at the same time, it's also gonna create that pressure gradient that is necessary for doing dialysis. The leading complication of this fistula that we create, the seminobrestia fistula, would be a long-term complication, can be stenosis. That's because of the repeated cannulation that you are doing. And lots of time when we do dialysis, there can be anaphylaxis as well. This anaphylaxis is basically reaction to ethylene dioxide, which is used to sterilize the dialyzer. So this is, routine complications are hypotension and increased incidence of heart attack, but even anaphylaxis can be reported there. Also, the filter that is used for doing hemodialysis made up of a biocompatible material. पहले वो cellulose का बना होता था, but now it is a biocompatible material that is like polysulfone. There are obviously different materials available now, but this is one of the common ones that they can be asking you, and what we don't use is cellulose filters at the moment. Then there can be development of seizures. Earlier, I was saying that a person of CKD can develop seizures, that is water intoxication due to volume expansion, but then the person can develop seizures at the end of dialysis. So first time जब dialysis करते हैं तो we don't do it for like 4 hours. We do a dialysis for, let me say, only 2 hours the first time, because when you will do aggressive dialysis the first time, then you suddenly are removing lot of urea from the body. So the osmotic gradient across the brain changes, and that can cause a cerebral edema and development of seizures. So if he says that patient is having seizures at the end of dialysis, then answer it as the word dialysis disequilibrium, which in MCQ language can also be written as reverse urea effect. What we mean by the reverse urea effect is that earlier urea was like very high, it was going in the brain, and along with that water was also going. Now you have suddenly decreased the value of urea, so therefore like that fluid shifts across the brain can contribute to a cerebral edema. And in NEET PG has also asked like what is the drug that is used for management of this dialysis disequilibrium. So because I said there's a swelling in the brain, there would be a cytotoxic cerebral edema, so mannitol needs to be used. Plus another complication that can be seen due to recurrent hemodialysis is dialysis dementia. That dementia here is occurring because of deposition of A beta 2 amyloid. In contrast, I want to remind you that in Alzheimer's disease, we have A beta amyloid, and here it is A beta 2 amyloid that would be involved. And I'll summarize this in the subsequent table. Let's do a question here. The question said all of the following improve with dialysis except. So if I'm doing dialysis in a patient, I can remove excess of protons, I can remove excess of potassium, and I can remove excess of fluid from the body, which is also causing pulmonary edema. These patients have pedal edema, they have pulmonary edema, breathing difficulty you would have noticed in patients of CKD. So I can remove all of them, but the damage to the kidney, damage to the bones, I can't reverse now. If person is already having elevated PTH and that's removing calcium from the bones, then by doing dialysis, I can't take care of the osteodystrophy like I was describing. PTH is more, bone turnover is increased, osteitis cystica fibrosa is developing. So if there are cysts in the bone, I can't do anything about it. So my answer for this question would be option number A, which is an important question from the previous years. Let's do a quick recap of the complications of recurrent hemodialysis. If I remove the word recurrent, I'll answer it as hypotension, but otherwise it is accelerated atherosclerosis. The dialysis dementia component is because of deposition of A beta 2 variety of amyloid. Dialysis disequilibrium is due to over dialysis that was done in a patient. It's also called as reverse. It is also called as reverse urea effect. So first time when we do dialysis in any patient, we should be doing it not for 4 hours, but only for 2 hours. And if I do this aggressively due to administrative reasons, or I did not realize the patient is undergoing dialysis first time, there could be a medical legal litigation and a dialysis disequilibrium cerebral edema managed with mannitol. Then obviously because you're putting a catheter, a tunneled catheter through which like dialysis is being done. So it's a double lumen catheter that we are putting in the seminobrestia fistula. So air embolism, hemorrhage and sepsis are big time complications. In children, we can also do a peritoneal dialysis where a special catheter will be put and we'll be inserting about 1.5. We'll be sending about 1.5 to 3 liters of dialysate in the peritoneal cavity of the patient. Peritoneal cavity has a very good big surface area, so exchange of solutes can happen. And the catheter that is put is having these cuffs present. It's a tunneled catheter so that the chances of infection would be lesser. Infection can still go. That is Staphylococcus aureus peritonitis can occur. That's the first time you will ever read about Staph aureus peritonitis with peritoneal dialysis. The amount of fluid that you send in is about 1.5 to 3 liters. And mostly for peritoneal dialysis, the catheter that is used is called as Tenkhoff catheter. This Tenkhoff catheter is surgically inserted in the peritoneal cavity, and the complication that can occur is peritonitis, but not due to like E. coli, like in spontaneous bacterial peritonitis in an ascitic patient. This is caused by Staph aureus, and then we cannot do a dialysis if person is already having a peritonitis, abdominal surgery, diverticulosis, or presence of adhesions in the bowel. Coming to the kidney transplantation aspect, the old kidneys are not removed. You can see that the diseased kidneys will remain in place. The new kidney will be placed where? That is in the right iliac fossa of the patient. So one, I want you to remember, though it's given in the diagram, if you are the donor for somebody in your family, then which kidney of yours would be removed? So what will be removed from like your body would be the left kidney. And where will it be placed? It will be placed on the right hand side. So we remove the left and we put in the right one. The rationale for that is that the left renal vein is longer. Since the left renal vein is longer, we can do better anastomosis. And you can also see the anastomosis with the bladder would be for the ureter also. No? If I place the kidney in place of the old one, Then the problem is that the ureter length is very long, 25 centimeter. Even the blood supply of that has to be taken care of. But here, like the small ureter will directly connect to the bladder, and the kidney will start functioning by default. Like once you connect it to the iliac artery, like you can see here, the blood supply is coming from the iliac artery of the patient, iliac artery of the recipient. The new kidney will add about 15 years to the lifespan of the patient, as I explained to you, but sometimes the disease can reoccur. So he can say that which kidney disease can reoccur and which will not reoccur. So one that usually has a tendency to reoccur is a cause of membranoproliferative glomerulonephritis. When you read about MPGN, there are two varieties, that is type 1 and type 2. So the dense deposit disease has a high tendency to reoccur because it's based on the immunological system and complement mediated damage to the kidney in MPGN. But one lesion that will not reoccur after kidney transplantation is a genetic condition by the name of Alport. Alport is a genetic condition of type 4 collagen. There's a COL4A gene which is defective. Now, when you are gonna be changing the kidney, you're giving a new kidney to that guy who's already having a type 4 collagen defect. But then it's not that the new kidney will also develop a type 4 collagen defect. No. So the next question that I've written, the one that I'm writing at the moment, is much more logical to work out, that in Alport syndrome, there is no rationale of like the new kidney developing Alport, because you have changed the kidney, right? Now collagen defect will not occur. But in dense deposit disease, you have changed the kidney, but immune system is still the same. So if the complement system is still attacking the kidney, the disease will reoccur in the transplanted kidney. Then there was a question like, which of the following is an absolute indication for urgent hemodialysis? Let me say you are listening to me right now, and you get a message from a distant cousin of yours from whom like you have not listened to for like a very long time, right? Let me say you get a message today on your mobile phone while listening to me at this moment from a distant cousin, not in touch with you for like years altogether. He says, buddy, sorry to disturb you. I know that you become a doctor. I just want a second opinion. Lots of time you'll be getting calls like that, second opinion. So he says that my dad is currently in the hospital. The hospital is putting pressure on me to give signatures for urgent dialysis. He says that the hospital is saying that if you will not agree, then like we will write on the case file that you have refused like that urgent intervention. Like he's saying that I just want to know that is it like the hospital is just trying to save some extra money, they're trying to rip me off, there's some scam going on, that they're saying put signature right now and give consent for like the dad has to undergo a dialysis immediately next 1 hour, or is it like can we wait? So he says, buddy, I just needed your opinion. So among the 4 options, uremic pericarditis, melena, encephalopathy, and asterixis, just think of which would you be advising that, okay, dialysis needs to be done right now. I mean, you'll say, okay, I'll give a break from the class. You attend the call and you say, buddy, give permission for dialysis now. Yes, guys. Among the 4 which are present, pericarditis, melena, encephalopathy, asterixis, let me give a rationale. Uremic, melena, lower GI bleeding. I mean, I still, if I wait for a few hours more and I take an opinion from another doctor, it's not going to change much prognosis. Uremic encephalopathy, even if I do, patient is unconscious, let me say right now, even if I do dialysis after 12 hours, he'll still be unconscious now. But uremic pericarditis, yes guys, very shocking. Uremic pericarditis is an absolute indication for dialysis. Why? Because urea is a toxin. It causes development of bleeding, and now in uremic pericarditis, where is the bleeding occurring? The bleeding is occurring in the pericardial space. If you will be having bleeding in the pericardial space, the blood will accumulate and will squeeze the heart from outside. It will contribute to development of cardiac tamponade in the next 1 to 2 hours. And once a person will develop cardiac tamponade, the BP will crash. The patient will go into obstructive shock. And then even if I do pericardiocentesis, I may not be able to save the patient. Better be late than never. Remove the toxin, urea from the body, and the uremic pericarditis and the bleeding part will be mitigated, and the chances of going into cardiac tamponade will be lesser. The absolute indication for urgent hemodialysis, though all of these that I've written are indications for dialysis, but an absolute indication for dialysis is uremic pericarditis. When I was a student your age, this question came to me in my wards. My consultant asked me among these, like, which is an absolute indication for dialysis. So I said uremic encephalopathy. He told me, get out. He said, get out, go to the library, read and come back. So, and earlier times, like it was a little more like humiliating experiences in the wards. Now it's like, I think maybe better. I'm not very sure. Somewhere things are still bad. Toxicity is still very much present, but it's bad. Like, senior doctors should not be ridiculing young doctors in front of patients. Like if they're scolded in person, na chalta theek hai yaar, senior hai. But then like in front of patient, it's really humiliating. I felt very bad. So just thought, while discussing this just came up because this has been asked in the exam also. Maybe the same consultant created that question, absolute indication for urgent hemodialysis. Okay. Which of the following is not an indication for urgent hemodialysis? So in a negative sense is saying which of the following is not an indication. So pericarditis though I have to do no, because patient will go into cardiac tamponade. Encephalopathy I will have to do maybe after 12 hours because I need to make the patient conscious, and encephalopathy causes hysterexis. No? You'll ask the patient, like, in before he goes into encephalopathy, you might be able to see hysterexis in a patient. So ammonia intoxication in fulminant hepatic failure or uremic encephalopathy both cause hysterexis. So if hysterexis is caused by uremic encephalopathy in the early stages, I would like to intervene. But for hyperkalemia, guys, I can give calcium gluconate. I can be using insulin drip in a patient. If I was saying the word refractory hyperkalemia, medically refractory hyperkalemia, it will also become an indication for dialysis. So I will make a list for indications for dialysis in like a couple of minutes from now. But I want to say to you that in both of these questions, the answer is turning out to be different from what normally I have seen students answering. Like with respect to the first question, usual answer is encephalopathy. I myself answered that, and not an indication for urgent hemodialysis. I usually get answers between hysterexis and pericarditis. The answer is hyperkalemia, guys, because in hyperkalemia, I can give calcium gluconate, I can give insulin drip to the patient. If it will still not respond, that's when I'm going to plan a urgent hemodialysis. Now, since we spoke about kidney transplantation, we also need to understand two more important aspects. Because after kidney transplantation, patient would be put on anti-rejection medication. Most of the time, the anti-rejection medication would be drugs like cyclosporine, azathioprine, prednisolone. So when you are giving these drugs to the patient, then the immunity of the patient will also begin to reduce. The anti-rejection drugs that are used on as maintenance therapy would be like cyclosporine, azathioprine, then prednisolone, and we also have other drugs also, like sirolimus, tacrolimus available. So at this moment, my point is that if I'm going to be using steroids in a patient, or I'm going to use tacrolimus in a patient, then over a long period of time, there is bound to be immunity issues, and the opportunistic infections can come. The most common opportunistic infection that leads to graft failure after 3 months of kidney transplantation. 3 months is not important. Focus on the image. And when you focus on the image, you can notice that basophilic inclusions, I'll use a different color, basophilic inclusions in the nucleus. These basophilic inclusions in the nucleus sometimes can be associated with a smaller inclusion body in the cytoplasm. Not very clear, but in this image, you can notice a basophilic inclusion in the nucleus, and there's a halo around it. No, like you can see some clear area present here. So this would be a feature of owl-eye appearance of cytomegalovirus. What happened in NEET PG was that they gave an image here. And when it comes to like FMG exam, there was no image, it was only a theory. But what you can see here is a owl-eye appearance. What you can notice is a basophilic, that's a blue basophilic intranuclear inclusion. Along with this intranuclear inclusion, also present is a perinuclear halo. So lots of time in this condition, there can be a intracytoplasmic inclusions as well. But even if you're not able to see that intracytoplasmic inclusions, chalega, there is still virus present in the renal tubular cells. These are the damaged or the damaged renal tubular cells. They're infected with cytomegalovirus, and therefore, like for cytomegalovirus, 2 times in a career we read about it. One is for that AIDS patient truck driver who became blind, and second is CMV. First time is CMV retinitis, and the second time is at the moment for cytomegalovirus contributing to graft failure after solid organ transplantation. Now they changed the question. In the INICET exam, they gave a similar kind of a question with a person undergoing a kidney transplantation. But they changed the time frame to after 8 months, and time is not important. More important is that when you look at the image, it's slightly different. Like if I try to hand draw this, I can say that this time what I can see in the cell is towards the periphery. Like if you look at the cell in the periphery, there is like a blue marking present. So I can just use a different shade of blue to highlight that. Like there's a ring of blue in the periphery. there's a ring of blue in the periphery of this particular cell. So at the moment, the cell that I'm talking about is what is called as a ghost cell, or it is also called as a decoy cell. I'll just highlight this once again. Let me say this is a shed renal tubular cell, the initial one that I made. I'll just do it again. This is the renal tubular cell. And then there's a ring in the periphery of the cell. This is again a basophilic inclusion in, basophilic cytoplasmic inclusion, but it is like in the form of a ring. So this time the word that we are using is called as a decoy cell, and this decoy cell is indicating the presence of polyoma virus, which is also called as BK virus. Guys, if you are an FMG student, you still have to study this. Don't think that just because I said INICET, you can zone off. No, guys, INICET questions are repeated in FMG exam as well. Like lots of time verbatim the question is repeated. Obviously, like in INICET, it is multiple correct answers. Here it's like a single correct answer to be remembered. But now you know that there are two opportunistic infections that can occur with respect to kidney transplantation. Cytomegalovirus is more common in the 6 months, and polyoma virus or BK virus is more common after 6 months. But then time frame is not an absolute criteria. It is the finding that is given is an absolute criteria. And instead of writing the word kidney transplantation, they may sometimes write the word SOT, that is solid organ transplantation. So because of anti-rejection drugs, the immunity is lesser. The last time I spoke about like opportunistic infections was with respect to HIV positive patients, but today I'm describing it with respect to kidney transplantation. Then there can be one more reason why the graft may not function optimally, that is graft rejection, because no two human beings are alike. In allogenic kidney transplantation, I'm going for HLA matching, but no two human beings are alike, so they can be graft failure. Hyperacute rejection can occur immediately. The time frame for hyperacute rejection will be that even before the surgeon closes the abdomen, like vascular anastomosis would be done, and within like minutes of vascular anastomosis, the preformed antibodies can cause the organ to become cyanosed and mottled, that is type 2 hypersensitivity. For the acute variety that is occurring in the very first 6 months of kidney transplantation, my answer would be type 4 as well as type 2. Both components are there, cellular as well as the humoral component. And for chronic, obviously, there is no such discrepancy. After 6 months, if the transplantation, SOT, solid organ transplantation, if there's a graft failure, then it would be type 4 delayed hypersensitivity. So nobody will mess up with the chronic variety, but for hyperacute, it is 2, and for the acute, it is both 4 as well as 2. These are like hypersensitivity reactions that can occur after SOT, that is solid organ transplantation. And one more statement I'll say that verbally. Most common virus causing graft failure after hematopoietic stem cell transplantation. If he says the word bone marrow transplantation, the answer still remains what I had mentioned earlier, that is cytomegalovirus. Even by default, even if you're not able to read the slide, guys, just by default answer it is cytomegalovirus. If he mentions after 6 months, answer it as BK virus, though ideally you should be able to identify the slides that I've currently shown here before you. Now we will focus on acute kidney injury. The main aspect to be remembered is the KDIGO criteria for acute kidney injury, where like serum creatinine of the patient is bound to rise. So serum creatinine should rise by how many times above the baseline that we'll say that the person is having stage 1. So your answer would be 1.5 to 1.9 times over the baseline value. Whatever is the baseline value, 1.5 to 1.9 times over it, over a time span of how many days. So your answer would be about approximately 7 days. If the serum creatinine is showing such a significant rise, it means patient is going into acute kidney injury. Normal urine output is 1 ml per kg per hour. If the urine output of a person decreases to 50% of normal, that is 0.5 ml per kg per hour for 6 consecutive hours, I'll say it is stage 1 of acute kidney injury in a patient. Stage 2 is less likely to be asked because most doctors will never make a mistake. If the serum creatinine of the patient rises to 2 to 2.9 times of normal, so 2 and 2, most people are unlikely to make a mistake. The urine output of the patient is still decreased to 50%, 0 by 2, 0.5 is 1 by 2, so 2 value coming again for 12 consecutive hours, then we will say that the person is gone into stage 2. As far as stage 3 is concerned, then there would be minimum tripling. The value of serum creatinine of the patient is rising to more than 3 times of normal. or for that matter of fact, the absolute value is more than 4 milligram. There are two data to be remembered here. Either it is more than 3 times for normal, or absolute value is more than 4. In all of them, the rise part that I'm describing before you is over a period of 7 days over the baseline. Like 1 week ago, last Saturday, this guy was drinking beer at a pub, and now he is like admitted in your hospital for maybe a scheduled hemodialysis because his kidneys have shut down. So that is like over 7 days, that description that I gave. And here, like when it comes to urine output, it would not be 0.5 and 0.5. It is 0.3 ml per kg per hour for 24 hours. So the numbers to be focused here would be 3 and then 0.3. It is very, very unlikely, in my opinion, that he'll ask you with respect to stage 3 or he will ask you with respect to stage 2, because most guys are able to pay attention and remember the data. So among the 3, he will ask you mainly stage 1, and that is logical also, now that we want to go for early diagnosis. At this moment, I want to add one more data in this discussion. In some MCQs, instead of writing for this stage 1 is 1.5 to 1.9, he might write it as follows: rise of serum creatinine by more than 0.3, like baseline was 1.2, now it's become 1.5 within 48 hours. So additional point to be remembered is, earlier I was saying over 7 days now, but instead of 7 days, if he says 48 hours, then an increment is 0.3 over 48-hour period, along with obviously the oliguria component. So initially I was saying time frame of 7 days. Why that 7 days I think is important is because if you look at this data, acute kidney injury, the span of acute kidney injury, this definition of acute kidney injury is valid for like the renal shutdown spanning over 7 days. But sometimes the damage of the kidney can cause the renal shutdown to last for a longer duration. When I say longer duration, it could be spanning over up to 30 days. Then I will say that the person is going into this. This is from like, mathematically, like there's a circle and then there's a second circle which is inside it. So I can go from onwards from 7 days. In fact, the data here will be between 7 to 30 days. And then when it comes to CKD, then already explained to you the difference would be eGFR of less than 60 ml per minute for 3 consecutive minutes, 3 consecutive months. But I wanted to bring to your attention the time frames here. The time frames, I'll say once again verbally, are 7 days, 7 to 30 days, and then after 3 months that the kidneys are asking for help. And these are some mathematical inputs which are to be remembered. Acute kidney injury, the topic that I'm teaching at the moment, is one of the number one reason why a patient would be admitted into intensive care unit. Two primary reasons for admission to intensive care unit either is sepsis or is acute kidney injury, or it is sepsis induced acute kidney injury. In our hospital, when you check the data in your register file, you will notice that majority cases admitted to intensive care unit are either AKI or they are having like sepsis. The urine output will drop dramatically to less than 100 ml per day. The markers of acute kidney injury, I have initially told you the classical definition, but nowadays, like the point is, why should I wait for 6 hours? Why should I wait for like as long as 12 hours or 24 hours? And why should I be comparing with baseline? Like if I don't have a baseline value, I am clueless. So what I'm saying is, patient's perspective is, why should I wait for 6 hours? No, in 2 hours, tell me kidney is damaged or not. Within 1 hour, tell me kidney is damaged or not. I'll give an example. Like in cardiology, I told you first hour we can diagnose with MI by doing a test that's called as ischemia modified albumin. 1 to 3 hours we can go for hard fatty acid binding protein. In the same spirit, I'm trying to say that if I want to do an early diagnosis, then these tests are available. That is cystatin C. This is a product produced by nucleated cells. Then we can go for NGAL. I'll write down the full form of this also. When you read about this biomarker of acute kidney injury, it looks like some test which is gonna be from the immunity perspective, but no, like this test is not from immunity perspective. This test is from the kidney perspective. The name is neutrophil gelatin associated lipocalin. This NGAL can be checked in the urine of a patient. Then we can check for urinary interleukin 18. And another one that I'm gonna write before you, it looks like some marker related to the bone, that is osteopontine, but is actually a marker of acute kidney injury. In fact, here I would like to add a suffix, biomarkers of acute kidney injury is what I've explained. Just like I've taught you in the cardiology section, biomarkers of MI as ischemia modified albumin, heart fatty acid binding protein, troponin I, troponin T, CPKMB. In the same spirit, the biomarkers of acute kidney injury are to be remembered in the sequence of cystatin C, neutrophil, gelatinase associated lipocalin, urinary interleukin 18, and osteopontin. The most common type of acute kidney injury is the prerenal variety. The meaning of the word prerenal variety is that the perfusion of the kidney is bound to decrease. Now let's do a question here. Pre-renal will be seen with all of the following except so one, drugs can be causing it, ACE inhibitors and NSAIDs. ACE inhibitors, why? Because they'll dilate the efferent arteriole. If you dilate the efferent arteriole, then the problem is that the filtration gradient can be lost in those patients who are volume depleted. So I'm not saying that ACE inhibitor will cause a AKI, but in person who's already having a volume depletion, ACE inhibitor should not be given because it will dilate the efferent arteriole. The guy is already hypotensive. The filtration gradient will be lost and the kidneys will shut down. So we can get a pre-renal acute kidney injury with even ACE inhibitors, but in the prefix is volume depleted patients. NSAIDs will inhibit prostaglandin production. That again, like prostaglandins have a renoprotective effect. Prostaglandins protect stomach mucosa, they protect kidneys, and like they help in maintenance of this balance between afferent and efferent arteriole, so can contribute to it. Burns will cause volume depletion. Burns will cause volume depletion. So I'm left with only one, viper bite. With viper bite, what will happen is that there would be hemolysis. I mean, you are aware of the fact that this is hemotoxic. So there would be hemolysis occurring in the body of this patient. The guy will be having extensive bleeding. That is okay. I mean, viper bite will contribute to hemolysis. Viper bite will contribute to bleeding, understandably. Bleeding from the lips, bleeding from the gums, sometimes bleeding from the eyes can happen. So like, I mean, hemotoxicity will cause bleeding, but they can be hemolysis also. And because of hemolysis, the hemoglobin that is released can block the tubules of the kidney, and it can result in development of tubular necrosis in a patient. So that would be a renal cause. So therefore I've answered it as option number C. The preferred fluid for taking care of patients of acute kidney injuries, normal saline. Most of them are pre-renal varieties, so perfusion is already less. They're already dehydrated, they're already volume depleted. So volume depletion can be taken care of by giving normal saline to the patient. And now I'll attempt one more question. This is from FMG exam. He gave a question on a child with diarrhea with severe dehydration and oliguria, and then he gave a couple of these parameters like serum creatinine was elevated, urine osmolality was elevated, and urinary sodium was on the lower side. So he said, what is the likely diagnosis? Some guys solved it by simple logic. Dehydration given, so perfusion of the kidney is less, so it will be by default pre-renal variety. But let's work it out also. In the pre-renal variety, what will happen is that the urine of the patient will become concentrated. And because the urine will become concentrated, you see, if you don't drink water the whole day, then your urine will become concentrated. Similarly, here, if the person is having dehydration, urine will be concentrated. So urine osmolality is always more than 500 milliosmoles whenever pre-renal type of kidney is present. The second pre-renal AKI is present. The second aspect is that whatever is sodium present in the tubules, the body will try to absorb all the sodium, all the water. You see, there is 180 liters of ultrafiltrate present in the tubule. If there's a dehydration happening, the body will try to get back all the water. Body will try to get back all the salt. Now just focus on the words I said. Body will get the salt back into the body. If you get the salt back in the body, what will happen to urinary sodium of this patient? Then the value that will be given will be dismally low. So what I've tried to give to you or explain to you is that even if he had not mentioned diarrhea with severe dehydration, on the basis of labs also, the answer would be given as pre-renal variety of acute kidney injury. Moving to the next question, he says electrician is admitted to the emergency room with the burns and a passage of red color urine. So electrical burns are present and there is a red color urine that is happening in the person. So the probable answer would be that the electrical current caused damage to the skeletal muscle. There is a presence of rhabdomyolysis. I'm getting more evidence because he's also saying that creatinine, phosphokinase, values are elevated. So skeletal muscle damage is causing rhabdomyolysis and myoglobin is having a reddish color. The serum creatinine is 4. So that tells me that the person has already gone into stage 3 of acute kidney injury. And he says, which of the following will be seen in this case? So when kidneys will fail, then what will happen is that the phosphate of the patient begin to rise. And this phosphate will chelate with calcium. So therefore, there would be like calcium to be decreasing. Whenever kidney is damaged, we rather have is a hyperkalemia, we have a hyperphosphatemia, and whenever kidneys will shut down, we also have is a gradual rise of magnesium because it is not getting excreted. So he's asking which of the following will be seen. That is because of the phosphate binding with calcium. That's why the answer to this question is option number A. Moving to the next question, what is the leading cause of renal failure in a case of multiple myeloma? The manifestations are called as CRAB, hypercalcemia, renal failure, anemia, and bony lytic lesions. So the answer here is hypercalcemia. Then we can have post-renal acute kidney injury also. Post-renal acute kidney injury will mainly be because of bladder outlet obstruction. And one of the important causes of bladder outlet obstruction can be an enlargement of the prostate. This patient of benign prostatic hyperplasia, I had suggested him to take tamsulosin, take finasteride, and then after that I also plan to do a TURP in this patient. But because a patient of benign prostatic hyperplasia did not get any surgery done, then the obstructive uropathy that can occur due to bladder outlet obstruction can result in post-renal variety of acute kidney injury. Now I introduce a very interesting term by the name of non-oliguric acute kidney injury. What I mean by the word non-oliguric acute kidney injury is, look at this data. Urine output of the patient is rather more. All through the damage to the kidney, I'm saying, oh man, kidney urine output is less. Oliguria, I was saying, anuria, urine output less than 100 ml. But now what I'm saying is that present in our collecting duct also, there is some receptors by the name of V2, and they are responsible for reabsorption of water. If the damage occurs due to agents like aminoglycosides, like gentamicin, for example, or netilmicin, these are like, aminoglycosides which can cause substantial amount of kidney damage, and kanamycin, these can cause damage to the V2 receptor. In fact, kanamycin will be having damage to the ear predominantly. Netilmicin, like for example, could be having significant damage to the V2 area. And because this V2 will be damaged here, so therefore water will not be absorbed, and rather instead of having like a oliguria, you would be having, though the kidney is getting damaged, but then the parenchyma of the kidney is getting damaged by the antibiotic, but there's a polyuria. So the causes for this could be one, acute interstitial nephritis, which could be caused by antibiotics. One of the antibiotics that can cause acute interstitial nephritis is like vancomycin. Then is contrast-induced nephropathy, CIN, contrast-induced nephropathy. I'll talk about the treatment for this also in like a couple of minutes from now. And then aminoglycosides, they all cause non-oliguric renal failure. Again, a very peculiar statement because normally whenever kidney is involved, there is bound to be oliguria. But 3 examples are where you get polyuria present. Then is a topic which I've discussed separately in hematology, but I'll just introduce it here, tumor lysis syndrome. This is usually seen when you give chemotherapy to patients with cancers. One of the highly aggressive cancers that has a tumor doubling time of 48 hours is Burkitt's lymphoma. So when you give chemotherapy to somebody with Burkitt's lymphoma, when you will kill the cancer cells, then killing of the cancer cells will break down the DNA. The breakdown of DNA will result in more production of uric acid, and this uric acid levels can be so high that they can block the tubules of the kidney. So what I've shown at the moment is, let's say this is the descending limb of loop of Henle, and then the ascending limb. So uric acid crystals are physically blocking the tubules, so the urine output of the patient will bound to be shut down. That will explain the renal failure that is occurring, and there are uric acid crystals which are causing problem here, so I'll have to use rasburicase. Plus all cancer cells are loaded with potassium. So any cell is loaded with potassium. When you kill so many cancer cells, potassium will rise. Plus all cells are loaded with ATP. ATP is the source of energy, it's the energy currency. So ATP means adenosine triphosphate. So phosphate will be high, and by default you can see that when phosphate will be high, calcium will be low. So there are 3 things that are becoming more. That is, uric acid levels are rising, potassium is rising, phosphate is rising, and calcium values are becoming lesser. How to remember that is puke calcium. When you puke, when you vomit out something, then something becomes lesser. When you lose out something, right? It's just a mnemonic, puke calcium. Not that vomiting is happening in this case. Puke calcium is a mnemonic to remember this information that when you puke, you lose something. So calcium is becoming lesser, and all the remaining things, P for phosphate, U for uric acid, as well as urea will rise, and K is the potassium values that are rising. And as far as causes of acute kidney injury are concerned, one of the leading causes can be like sepsis or shock. I'm not classifying them into now pre-renal or renal or post-renal. I just want to say that sepsis, toxins, obstruction, and parenchymal causes are some of the important reasons that can cause kidney shutdown. Then he will give you special situations like renal failure after coronary angiography. If he will give you a situation where he will say that renal failure occurred after coronary angiography, and he also notices that after like angiography after 2 days, like let me say after 48 hours in the patient, what is happening is that there is a development of livedo reticularis, that is like a fishnet appearance of blood vessels. There's a rash, there is blue colored toes, and the urine examination of the patient is showing eosinophil. I mean, you don't read the word urinary eosinophiluria ever apart from the topic that I'm explaining to you. This is a very classical situation where what has happened is that during angiography, the atherosclerotic plaque against which the guide wire was traveling got damaged by the guide wire, and the fragments of the atherosclerotic plaque are now traveling downstream from the aorta into the renal artery and are causing an atheroembolic kidney disease. Guys, this is a complication that can be seen after coronary angiography. Why? Because I said when you do angiography, you have to send up a guide wire from the femoral artery towards the coronary artery. So it's scraped against the atherosclerotic plaque in the descending aorta, and the atherosclerotic plaque fragments got disseminated into the renal circulation. So there's a renal shutdown. That's understandably because the atherosclerotic fragments, cholesterol fragments, will block the small branches of the renal artery. But apart from this, like you would get this distributed to the lower extremities also. So the atherosclerotic fragments can contribute to even like blue toes or even like digital gangrene that can occur in these patients. The second cause can be contrast-induced nephropathy. Like there was a health camp organized by my hospital. There was a lot of load, and a diabetic patient underwent a coronary angiography. Unfortunately, like I had not checked his baseline creatinine levels, which are already elevated. Now, when we will give iodinated contrast to somebody, then iodinated contrast should have been given in a lesser dose, or I might not have done angiography in the patient. But since I did angiography, the contrast that I've given will cause damage to the kidney and will cause a CIN. That would be a non-oliguric renal failure. The KFT of the patient will be deranged, but there will be no anuria. It would be rather a polyuria present. For management of this condition, what is recommended is simple hydration. And like earlier, the antidote for this condition was like contrast induced nephropathy was like the same antidote for paracetamol toxicity, that is N-acetylcysteine. But currently the status of this is that it is not recommended for management of patients of CIN, that is contrast-induced nephropathy. So 2 times after angiography, the kidney can fail. One is going to be contrast-induced nephropathy. Second is atheroembolic kidney disease. And atheroembolic kidney disease can be picked up on the basis of rash, blue toes, and urinary eosinophiluria. In fact, urine eosinophils, whenever you read about urinary eosinophils, what are the differentials that you should be keeping in your mind with respect to urine eosinophils are urinary eosinophiluria can be seen with acute interstitial nephritis, which is seen with like vancomycin. Second is it can be seen with schistosomiasis. Understandably, parasitic infestation can be having it. And the third one is what I've just explained to you, that is atheroembolic kidney disease. In this condition, the baseline KFT will be normal. Another hint, contrast-induced nephropathy, baseline creatinine was already elevated. I did not check out the creatinine was elevated and I got a angiography done. But in atheroembolic kidney disease, like baseline serum creatinine is normal. It is after the procedure that we are having this significant rise in serum creatinine of the patient. So urinary eosinophils can be seen in the following situations, including a parasitic infestation. Then he will give you a situation of renal failure after dysentery. If he mentions that the kidneys are enlarged, then always answer it as renal vein thrombosis. But if he specifically mentions the kidneys are normal and peripheral smear shows cystocytes, then your answer is hemolytic uremic syndrome. Remember, in hemolytic uremic syndrome, kidney size will never be increased. But renal vein thrombosis, yes, the kidney would be, bilateral kidneys would be increased. There are 3 causes of renal vein thrombosis from the age group perspective. If he talks about a child, and he says child is having renal vein thrombosis, then it will mostly be diarrhea with dehydration, and the dehydration will cause like erythrocytosis in a relative sense, and therefore like the concentrated blood flow, sluggish blood flow can cause renal vein thrombosis. If he says adult, then this is associated with nephrotic syndrome, that is membranous glomerulopathy. And if he gives you a geriatric age group patient more than 65 years of age and he says there's a renal vein thrombosis, then answer it as renal cell carcinoma. If you get renal failure after dysentery and there's normal sized kidneys, urine osmolality is more and urinary sodium is low, then I've already explained to you this aspect that this would be a pre-renal variety of acute kidney injury that would be occurring in a patient. As far as the pathophysiology of changes are concerned, hyperkalemia understandably because inability to excrete potassium. Kidney is responsible for excretion of potassium. There is an impaired ammonium excretion, that is the pathogenesis for acidosis. RAS system is coming into activation due to low GFR. That's why hypertension. Toxins are accumulating, so there would be uremia. And like I've already explained that in these patients, the amount of water in the body is disproportionate as compared to the amount of salt in the body. I put like 2 arrows for water and 1 for salt to say that this is hypervolemic hyponatremia, and therefore like edema would be present. It can be even, in fact, I can say that sometimes the edema in CKD patients can be so much that they can be having desaturation due to pulmonary edema, and the hypertension can cause a left ventricle failure because RAS is activated. So high renin hypertension can cause a LVF. As far as uremia is concerned, what are the symptoms? He'll always describe, and waste your time here by describing GI symptoms, because urea irritates the stomach mucosa and it also irritates the diaphragm. I said urea is a toxin. So irritation of the stomach mucosa will explain the nausea, vomiting always given in patients of renal shutdown. And because of the irritation of the diaphragm by the urea, which is a toxin, that is why hiccups would be given. Then he can mention regarding chest pain, that is because of the uremic pericarditis component that I've explained. And this is not to be taken lightly, because if a person is documented to have uremic pericarditis, he can end up with a cardiac tamponade also. Then the volume expansion can cause breathing difficulty. The saturation of the person will begin to fall. The combination of hypertension causing heart failure and volume expansion causing heart failure, both can be present. And then you could be having like CNS manifestations described with respect to asterixes. All of these points that I've written here before you will be distractions, because when you will write GI symptoms, you will think some like, gastritis or cardiac issues given, but all of these are features of uremia. After that, he will say that there is an anuria developing in a patient and like oliguria describing in a patient. So he'll not start with saying patient comes with complaints of oliguria, anuria. He'll first like 2-3 lines of the question. Like in FMJ exam, no, I've said that the just Lay's ke chips hote na, lot of air and like no substance. So here also, like in FMJ exam, when he gave questions on renal failure, they were like 4-liner, 5-liner. Reading them were taking a lot of time and they were all filled with gas. Like this is not like very, very diagnostic of anything. So subsequently mentioned that the patient is having manifestations of oliguria and anuria. And in patients of kidney damage, you initially have oliguric phase, but later in the same patient, the kidney function recovers. So we have a oliguric phase, diuretic phase, and a recovery phase as well. For the diuretic phase, you will now notice that patient will begin to improve. So creatinine will stop rising further. And in the diuretic phase, urine output will start rising more than normal. So you would have seen that patients of AKI, when they start recovering, they start passing more urine because tubules are not reabsorbing the water. And now instead of having a hyperkalemia, you could be having a hypokalemia as well due to aggressive use of diuretics. Mark my words there. In oliguric phase, potassium will obviously be elevated. All the things that I'm describing to you at the moment are findings with respect to the oliguric phase of acute kidney injury. The moment the patient, I would say, goes into what is called as the recovery phase or the polyuric phase, then the electrolyte imbalance will change to hypokalemia, though hyponatremia will still be occurring. So because we know that we have to make the patient go from this oliguric phase to the polyuric phase, what we can do is we can be putting the patient on hemodialysis. For hemodialysis, like the main principle of hemodialysis to be remembered is osmosis. There's other thing. Osmosis would mean that there would be loss of water. I mean, osmosis would mean that there is only loss of water, and this explains why hypotension was being discussed, and diffusion is the movement of the solute. So the combination of like loss of water and the solutes would help in removal of the toxic products from the body. I've already explained to you that nowadays we don't use that cellulose wala filters and we use polysulfone wala. The blood flow will be fairly extensive, 250 to 450 ml per minute. And how do you check for adequacy of dialysis? It is called as urea reduction ratio. It is called as urea reduction ratio. That is to assess the efficacy of like you have done a dialysis in a patient. Then miscellaneous question, any set wala. If an acute kidney injury patient is having hypotension, then we do hemodialysis with hemofiltration. We are removing, like he's having heart failure now, so there's a volume expansion, there's a lot of like fluid in the body. or like if there is hypotension, either of the two things, if they are given in a question, then we do dialysis with hemofiltration, which is called as continuous renal replacement therapy. CRRT is not done for uremia, guys. It is done for patients or uremia gone into either heart failure or have gone into hypotension. As far as indications for dialysis are concerned, I've already explained to you the most important indication is uremic pericarditis. This is a classical information that is given, that acidosis not responding to soda bicarbonate, pH less than 7.1, potassium which is refractory more than 6.5 in spite of the drug treatment, then drug intoxications, fluid overload, refractory. The word refractory coming 2 times, right? Refractory word has come up with respect to hyperkalemia, refractory with respect to pulmonary edema component, and then uremic pericarditis and uremic encephalopathy. So AEIOU is used to be remembered. The absolute indication would be a uremic pericarditis. The most common complication of hemodialysis has already been explained. You will lose water because you're doing osmosis now. You are also doing is apart from osmosis, diffusion. You lose solutes also, but then water loss can cause hypotension. Next, a couple of miscellaneous aspects to be remembered. We traditionally read about RBC cast in glomerulonephritis and WBC cast in pyelonephritis. उसने पूछा broadcast. Broadcast are seen in chronic advanced CKD. Like the size of like normal kidney may be normal urine of a person will also be having casts. So those casts are called as hyaline casts. These are perfectly normal. Hyaline casts are composed of TAM protein, so they're perfectly normal. But if the caliber of these is bigger, broad cast, that is indicating a CKD. In CKD, we don't have smaller cast, we have broader cast. The remaining nephrons will show a compensatory enlargement in the tubules to take over the function of the damaged kidney. So we don't have narrow or smaller cast, we have bigger casts present. Then is the urine specific gravity keeps on changing. Like if we drink a lot of water, then the urine will become dilute, and when we don't drink water, then like the urine will become concentrated. Isothenuria is defined as fixed urine specific gravity. Lots of time this is seen in patients of sickle cell anemia, that the tubules are damaged and they lose the ability to concentrate the urine. Fixed urine specific gravity of 1.010 is present. Then muddy brown granular cast are seen in acute tubular necrosis. Broad cast are seen in CKD, not smaller, broader, because I said that the nephrons, the tubules, remaining ones which are surviving will take over the function of the damaged one. RBC cast are found in acute glomerulonephritis, never an issue. Then is the finding of non-glomerular proteinuria. Now, this would always be less than 1 gram per day, and the major protein present here is beta-2 microglobulin, and this beta-2 microglobulin cannot be lost across the filter of the dialysis machine. So it keeps on accumulating, and it accumulates where? In the neurons. So you remember there was dialysis dementia. So I just wanted to bring to your attention, beta-2 microglobulin protein is like cannot be filtered across the dialysis filter. It keeps on accumulating and cause dialysis dementia. Then you will read the term dysmorphic RBC, or you might read the word acanthocytes. If you ever read any of these two terminologies, acanthocytes or dysmorphic RBCs, they always indicate a glomerular pathology. These are a couple of one-liners which are to be remembered at the moment. Then is urine dipstick negative for hemoglobin and myoglobin. Normally the dipstick can detect both hemoglobin and myoglobin. If it is negative and the urine is still red, then it is going to be porphyria. So now we know 3 reasons why urine can be red. One is obviously hematuria, second can be myoglobinuria, third is porphyria. Hemoglobinuria, myoglobinuria and porphyria, reasons where the urine could be reddish. Alport syndrome will always have a triad. The triad to be remembered will be anterior lenticonus, eye involvement, ear is sensorineural hearing loss, and then is like type 4 collagen defect, which will contribute to recurrent hematuria and ESRD. In this question, he will always mention father died of kidney failure, grandfather also died of kidney failure, and now this guy has come to the hospital with a decline of kidney function and has ear and eye issues. The electron microscopy finding is called as basket V pattern. We can do a PCR in this study for this particular gene called as COL4A5 gene, and the pattern of inheritance of this condition is why it is discussed that it is this disease can have any pattern of inheritance. It can be X-linked dominant, X-linked recessive, autosomal recessive. It can follow any pattern of inheritance, guys, but the commonest pattern of inheritance seen with this condition is X-linked dominant. Then a couple of questions, miscellaneous ones on color of the urine. Pink is seen with deferoxamine iron chelator, green with triamtrene. Triamtrene is a diuretic. It belongs to the thiazide class of diuretics. And then you would have seen, like, old lady admitted in hospital, and she's having catheterization, maybe because she had a gynecological cancer. She's catheterized for a long time, so you will notice her urine will be purple. This purple would be caused by these bacteria, that is Providentia, Klebsiella, or E. coli. The basic point is that in our body, tryptophan produces indole, but the problem is that this indole is then metabolized by the indole, which is produced normally in our body, is metabolized by these bacteria to produce the purple pigments and can cause this purple bag syndrome, as they call it, or purple urine to be present. Like purple discoloration of the hand can be seen with phenytoin extravasation, or purple discoloration of palms and soles can be seen with the patient having parvovirus infection. I'm saying that verbally because I've said it at different times. Purple discoloration of the hand can be seen due to extravasation of phenytoin. Purple discoloration of palms and soles can be seen with human parvovirus BB19. The same virus that causes slapstick appearance can cause purple glove and sock syndrome manifestation, that is purple discoloration palms and soles, and purple urine can be seen with Providentia, Klebsiella, and E. coli. So a lot of facts here for this particular slides that I would say, but covers a lot of questions. Now I will talk about nephrotic syndrome. Now, one of the features that can be given in these questions on nephrotic syndrome is that the patient is having passage of foamy urine. I can say, like, if you pour beer into a glass, or if you pour like cold drink into a glass, then there's a little froth at the top. So similar kind of description would be given by the patient for freshly passed urine noticed in the toilet seat. We can use a dipstick also, and dipstick of 4+ report means that the proteinuria magnitude would be almost like 5 grams per day. But on a comparison basis, dipstick versus quantification is important. We have to take a time 24-hour urine specimen. This time 24-hour urine specimen, patient must be told categorically that first day morning sample is to be discarded, and the second day's first morning sample is to be taken into consideration. We don't want both days first morning sample to be taken. It's the first day's morning sample that's discarded. And if we find that there is more than 3.5 grams of protein present in this patient's 24-hour day sample, that is like the definition of the word nephrotic range proteinuria. Now, since the predominant protein that is lost is albumin, so a lot of these patients will be having hypoalbuminemia, due to which ascites can develop and even pleural effusion can develop, that I'll describe in the clinical profile. Then there would be edema. As is the norm in all kidney diseases, the edema will always first start around the eyes, that is a periorbital edema. And then as the day will progress, it can migrate to the genitals. Now, this genital edema, that is vulval edema and scrotal edema, may not be noted by the patient. But yes, towards the end of the day, the patient is saying that I'm not able to like wear chappals in my foot, or like feet, like the feet are grossly swollen and is not able to wear shoes, or if the socks that he is wearing, that the band, elastic band of the socks will cause like a big mark on the lower extremities of this patient. So this would be a pitting pedal edema that is noticed. Now, the fourth feature that was asked in the recently concluded ANICET exam was that the patients on nephrotic can also be having hyperlipidemia. Yes, guys, the values of cholesterol, including the bad cholesterol, is elevated. So by default, it becomes clear that any kidney disease ultimately results in development of accelerated atherosclerosis. There is a hyperlipidemia, and because the lipids can be so high that these lipids could be coming in the urine of the patients also. So don't be surprised if you read the word lipiduria. If you read the word lipiduria with respect to description of nephrotic syndrome, what I'm teaching at the moment are essentials or diagnosis of this condition. I mean, these are the findings that can be seen. Lipiduria can also be written as oval fat bodies. That's again a very characteristic terminology to be used as urine routine microscopy of a minimal chain disease patient, or membranous glomerulopathy, or focal segmental glomerulosclerosis could be showing oval fat bodies. Then along with this lipidemia, hyperlipidemia, and lipiduria, the sixth manifestation is that in nephrotic syndrome, because it's a acute phase state, or it's like an inflammatory state present, so the values of fibrinogen in these patients can be elevated. You see, nephrotic syndrome is a condition where all proteins in the body can be lost. So don't be surprised if he says that the patient is having a deficiency of ferritin, which can cause a iron deficiency anemia like manifestation. Or like in a MCQ of nephrotic, he may deliberately mention the word low ceruloplasmin. He wants you to make you think in terms of Wilson disease. So agreed, in Wilson disease, ceruloplasmin deficiency is present, but even in nephrotic syndrome, ceruloplasmin deficiency can be present because it is getting lost in the urine. I can say by a general statement that all proteins in the body, will become lesser in nephrotic syndrome except one, fibrinogen, because one, the levels are elevated because it is like a inflammatory protein, and second, like I can say that this protein is too big to be excreted across the filtration slits in the kidney, and overall, like, because I said hyperfibrinogenemia, so therefore these patients would be having a hypercoagulable state. Yes guys, nephrotic syndrome is a hypercoagulable state, so you will hear me speak about this nephrotic syndrome again when I describe pulmonary embolism to you, because if a person is having a hypercoagulable state, then the risk of deep vein thrombosis will increase. If deep vein thrombosis incidence will increase, it will also increase the risk of pulmonary embolism in these patients. So these are like manifestations that are seen in nephrotic syndrome, that is having predominantly proteinuria. And if he says what is the leading cause of nephrotic syndrome in neonates, then for neonates, our answer would be given as the Finnish variety of nephrotic syndrome. It's more common in Scandinavian countries. It's also called as congenital nephrotic syndrome, that occurs because of genetic reasons. One of the proteins that could be defective here is because of a defective gene. In fact, the gene to be remembered here is called as NPHS1 gene, and the defect of this results in a protein being expressed lesser, that is called as nephrin. Nephrin is expressed in the basement membrane of the kidney. It helps in preventing the leakage of proteins. I told you normally albumin value is always less than 30 milligram, total protein is less than 150. So nephrin plays a role with respect to the filtration slit in the kidney, and the level of this protein in the basement membrane is lesser. Due to the defect of NPHS2 gene, there could be deficiency of this protein by the name of podocin. The message is that nephrin and podocin would be lesser in patients of this Finnish variety of nephrotic, and this is leading cause of nephrotic syndrome in neonate. So neonate will not have that pedal edema and then like subsequently periorbital edema. It will be more of a generalized anasarca. If I change the question to what is the cause in children, only for children, your answer would be given as minimal chain disease. I want you to remember the fact that when this question came in the exam for a newborn child, even there people casually answered as minimal chain disease, whereas age group wise minimal chain disease is what you encounter with respect to like pediatric age group 3 to 8 years. For minimal chain disease, he can also ask you why it occurs. So one of the important reasons is obviously the diagnosis of exclusion, that is idiopathic. But before that, I also want you to remember a question that will say that minimal chain disease is a paraneoplastic manifestation of which cancer. Just like you're comfortable that oat cell cancer can cause SIADH and can contribute to Cushing syndrome, with SIADH being more common, minimal chain disease can be a paraneoplastic manifestation related to Hodgkin's lymphoma. And then NSAID used in pediatric age group again can trigger or development of minimal chain disease. The question will begin by describing a child with periorbital edema. The edema will then migrate to the feet of the patient. So as I've explained to you that periorbital edema will be in the morning, like you can notice a lot of puffiness around the eyes of the child. The mother is thinking child is having some food allergy, like sometimes if somebody is having food allergy, they can be swelling on the face. But then she's also observing that the child is having breathing difficulty, and you notice that the child was pretty breathless. The saturation at room air was low when you put on a pulse oximeter. So you decided to get a chest x-ray done, and the chest x-ray findings were very, very striking. The x-ray findings were that there was a presence of like blunting of the bilateral costophrenic angles, because these patients, due to decrease in the oncotic pressure, will develop bilateral pleural effusion. This would be a transudative variety of pleural effusion, because of which he can also talk about Light's criteria. I'll not talk about Light's criteria. I'll just I'll not write them down. I'll just say them verbally. That Light's criteria would be having pleural fluid protein of value less than 0.5, and the LDH values would be less than 0.6. But the shortness of breath in this patient is explained by the development of a transudative variety of pleural effusion. The rationale is that Starling forces are lesser, and therefore third space effusion, so third space fluid accumulation can occur. This is transudative pleural effusion that would be seen in these patients, and also there would be ascites. Now the mother doesn't know what is ascites, so she is just saying that she brought a new dress for this girl child of the new year, and the child is having inability to wear the dress because the abdominal distension is there because of the ascites component. The type of ascites that is present here, I'll use a separate color to highlight it. I've discussed it in the liver section. Serum albumin ascites gradient, the SAG value will be less than 1.1. When it comes to cirrhosis, the values are more than 1.1, but with nephrotic, it is less than 1.1. Now with this child having swelling And like lots of time, if it's a observant mother, she may also say that my child has become very heavy, because when the kidneys will malfunction, there would be retention of fluid and salt in the body, so weight gain will also be noticed. I'll get a 24-hour urine protein done, and like how much should be the proteinuria that I can say that this is nephrotic range proteinuria. Then here don't answer more than 3.5 grams per day, because in children we don't take into consideration the 3.5 grams wala cutoff. What we take here is like for like more than 40 milligrams per meter square per hour wala cutoff. So remember, for pediatric cutoff, it's more than 40 milligram per meter square of protein present in the urine. The good news is the minimal chain disease has a very good prognosis, because KFT is normal, C3 levels will always be normal, electrolyte report will always be normal. So like the condition has a good prognosis, and in reality we don't do a kidney biopsy in this condition. This is academic discussion, so I'm discussing that the light microscopy findings of this condition will also be normal. That is why we tend to use the word minimal chain disease. A lot of people in the exam, they answered like effacement of the food processes of podocytes. That finding is valid for like the electron microscopy. Like if I say that in minimal chain disease there is a diffuse and a global food process effacement, it makes sense for electron microscopy but not for light microscopy. That's why the name is minimal chain disease. And this condition shows a good response to steroids. The steroids are given for 8 weeks. Usually the edema will begin to resolve in next like 4-5 days only. And for the ascites component or the pleural effusion component or the generalized edema component, especially swelling around the eyes, we can give spironolactone. So no role of ACE inhibitors in this case. It is spironolactone with prednisolone which is used. If he says what should be the protein intake in the diet, then it is normal 1 gram per kg. Like the mother is observant, so she's saying that should I be giving more protein to my child, because like can I add egg or chicken? I said no need, just need to give about 1 gram per kilogram per day. So normal protein in the diet is required, because usually in a couple of days we are able to control the proteinuria component. Now, if he changes the question and says what is the leading cause in adult population, then your answer would be given as MGN, or it could be FSGS. So first I'll mention the one which is more common in adult population, that is focal segmental glomerulosclerosis. For focal segmental glomerulosclerosis, some of the important causes are also to be remembered for primary versus secondary. So primary is obviously idiopathic, but for the secondary one, I especially want you to remember HIV associated nephropathy. Another cause to be remembered here is and in this condition, I will also be requiring a micturating cystourethropy, that is vesicoureteric reflux. One of the street drugs that's incremented in causing FSGS is heroin. So just like for minimal chain disease, I was describing paraneoplastic manifestation, idiopathic. Similarly here, it is HIV nephropathy, vesicoureteric reflux, and heroin abuse. That can be one of the few important causes for focal segmental glomerulosclerosis. Can you tell me the electron microscopy finding of focal segmental glomerulosclerosis? Yes, guys. Can you tell me? Electron microscopy finding of focal segmental glomerulosclerosis. Your answer would be effacement of the food processes of podocytes. Yes, guys, even in focal segmental glomerulosclerosis, we get effacement of the food processes of podocytes. It may not be diffuse, it can be focal, but then if you get a question in which there is a food process effacement happening, that food process effacement is a finding that can be seen in all of these. That is in Finnish variety also, in minimal chain disease also, and in focal segmental glomerulosclerosis also. The finding will change for MGN, that I'll just describe to you after 65 years of age. If he says what is the important cause of like nephrotic syndrome occurring in an adult population, then it is MGN. MGN will not be written as membranous glomerulonephritis. It is membranous glomerulopathy. Instead of membranous glomerulopathy, it may be written also as membranous nephropathy. It is MGN. It can be written as MGN, that is membranous glomerulopathy or a membranous nephropathy. This MGN is primarily because of an antibody. The primary variety is because of an antibody by the name of anti-phospholipase A2 antibody. It's an antibody against a receptor actually. Anti-phospholipase A2 receptor antibody. At this junction, I just want to recap what I've said for minimal chain disease, idiopathic, Hodgkin's lymphoma, NSAIDs. With respect to Finnish variety, it was genetic reasons. With respect to focal segmental, HIV-associated nephropathy, VUR, and heroin. And like after 65 years of age, in fact, I can add one more drug here also since I got an opportunity, that is pamidronate. And then after 65 years of age, there's an antibody that is associated, that is membranous glomerulopathy among the etiology. Another etiological risk factor to be remembered for membranous glomerulopathy is malignancy. It, like the question will say that a person is having renal cell carcinoma, or he can say prostate cancer, and person will develop which variety of nephrotic syndrome. So cancer associated nephrotic syndrome is membranous glomerulopathy, also called as membranous nephropathy. Or instead of like malignancy, another risk factor can be autoimmune disorders like rheumatoid arthritis, scleroderma, SLE, and you can say what can be the cause or presentation of nephrotic syndrome in them. The answer is MGN. So I've taught you a couple of peculiarities. For primary variety, it's obviously anti-PLAR, phospholipase A2 antibody, and actually we can measure the titer of this antibody. So lots of time biopsy is not even required. But for the secondary variety, the association with malignancy and autoimmunity needs to be remembered. Solid organ tumor associated nephrotic syndrome, or like autoimmunity associated nephrotic syndrome, is membranous glomerulopathy, written as MGN or referred as membranous nephropathy. Let's also revise the important findings here. For the Finnish variety, there is a mesangial expansion happening, and then the electron microscopy in this condition will also be like the food process effacement. This food process effacement word will come 3 times in this entire table, and I can say that obviously in the minimal chain variety, it will be more diffuse as a finding present. There are no immunofluorescence findings with respect to the Finnish variety. For minimal chain disease, the light microscopy finding is normal. That's why we call it minimal chain disease, but we get a food process effacement. And here I'm just prefixing the word diffuse food process effacement just to highlight the more aggressive stance there. Then for focal segmental glomerulosclerosis, the histopathological finding will be solidification of the tuft. In some areas of the glomerulus, there would be like a pink material present, which will look like solid material. Normally the tuft of capillaries is seen, but here solidification of the tuft would be present. The electron microscopy finding here also is a food process effacement. So when you read food process effacement, don't think alone in terms of like minimal chain disease. It can be Finnish, it would be FSGS. The age group will help in differentiating. And similarly for minimal chain disease, there is no immunofluorescence finding, but for FSGS, the immunofluorescence finding will show IgM antibody and complement 3 deposition in focal segmental associated with HIV nephropathy and couple of other examples. Then for MGN, it is a diffuse capillary wall thickness. For light microscopy, electron microscopy is very characteristic. That would be a spike and a dome appearance. So he might use the word initially like subepithelial. Remember, if you ever read the word subendothelial deposits, always think in terms of lupus nephritis, where you get wire loop lesions. But if you read the word subepithelial, and then he says subepithelial deposits, electron dense deposits in a spike and a dome appearance, then don't mix it with humps. I'll talk about the humps also. At the moment, it is subepithelial deposits. These subepithelial deposits are composed of granular immunoglobulin G and C3, and the appearance is also called as spike and a dome appearance. This would be like very characteristic for membranous glomerulopathy. And just for the sake of comparison, I'm introducing MPGN also, that is one in light microscopy having a tram track appearance. Then this is of 2 varieties, that is 1 and 2. So for the second one, the important terminology to be remembered by you would be presence of dense deposits. That is why it is called as a dense deposit disease. And you will also notice that in MPGN, I'm emphasizing on the word first granular C3 deposits. Obviously both are present, but predominantly would be the C3 deposits with immunoglobulin G. For the type 1 variety of MPGN, it is standard subepithelial deposits only, but there would be no mention of the word then spike and a dome appearance. And I rephrase what I said. If you read the word subendothelial deposits, then think in terms of lupus nephritis. So LM, EM, and immunofluorescence findings of these would help you in understanding and appreciating the disease process for the various varieties of nephrotic syndrome. Now we will be comparing this with nephritic syndrome. Now, when it comes to nephritic syndrome in a patient, I'll first focus on the slide. Like you can see a normal glomerulus at the moment, and this is where the ultrafiltrate would be accumulating. So one, I want to point out to the Bowman space, which is always very clearly visible in glomerulus of normal people. And then you can see the renal capillaries across which you would be noticing that some RBCs can also come. In fact, I can put that as a question to you guys. Do you get RBCs in the urine of a normal person? Just need to shake your head. I can't see you. Do you get RBCs in urine of a normal person? Yes or no? Then RBCs in the urine of a normal person are a big yes. Yes, guys, we do have RBCs in urine of a normal person, and the number would be less than 3 RBCs per high power field in a centrifuge sediment. Like you take a urine specimen of a person, you spin it in a centrifuge machine, then in a normal person, the number of RBCs will always be less than 3. As far as the definition of word hematuria is concerned, because here, like in nephritic syndrome, I'll describe the damage to the renal capillaries. So therefore, hematuria as a manifestation is having two definitions. The first definition is that there is more than 5 RBCs per high power field. But for this, I don't need like a single report. I need at least 3 consecutive reports that the person's urine specimen, when it was centrifuged under microscopic examination, is having more than 5 RBCs per high power field. On the other hand, if the second report is there are more than 100 RBCs, there are more than 100 RBCs per high power field, and a single report is sufficient for identification of hematuria. Additional feature that can be present is in the form of RBC casts. Even if a single RBC is seen, that again is sufficient for identification. So what you saw here was definition of the word hematuria. Though overall, if he says what is the most common cause of hematuria, if he says overall most common cause of hematuria, then don't answer it as like post streptococcal glomerulonephritis. The overall most common cause of hematuria is urological causes. Kidney stones must be ruled out, nephrocalcinosis must be ruled out, and only then we should think in terms of PSGN. So what I said was that there is the Bowman space. This is a normal glomerulus which has been shown at the moment, and we can have ultrafiltrate accumulating here. The amount of ultrafiltrate along with some RBCs less than 3 would be per high power field would be like the normal function of the kidney, and out of 180, 178.5 will be reabsorbed, and the remaining 1.5 liters is the urine. But now I want to point out to the glomerulus, which is bigger in size on the right hand side. If you look at this image, the first thing that you will notice is strikingly that there is a lot of blue deposits in this entire glomerulus. So what I'm showing here is a slide of a hypercellular glomerulus, and this hypercellular glomerulus, you can also notice there is complete obliteration of the Bowman space. No Bowman space is present here. So considering the fact that there is a hypercellular glomerulus and the Bowman space obliteration is occurring, so ultrafiltrate will literally be reduced to 0. And if the Bowman space obliteration will happen, the ultrafiltrate is being reduced to 0. So therefore there would be renal shutdown, and my patient will progress from a stage of oliguria to anuria. Like this patient says that my urine was coming less for last couple of days, so he drank more water also. But surprisingly, he says urine output is not increased, but my eyes have become more puffy because if input is more than the output, then there is gonna be like expansion of the plasma volume. The capillary, this area is the tubules. So you can notice the tubules of the glomerulus look decent for the normal image as well as for the hypercellular glomerulus. But now I want to just highlight why am I having a hypercellular glomerulus and what are the implications. So the patient of mine got infected with this bacteria by the name of group A beta hemolytic streptococcus, and you know that this can contribute to either sore throat in a patient or it can contribute to development of pyoderma. So unlike like in rheumatic fever where we have sore throats and then we have cardiac involvement, today we'll talk about a kidney involvement here in response to infection with this bacteria by the name of group A beta hemolytic streptococcus. This bacteria has antigens on its surface. Like any other bacteria, there would be antigens that would be present, and against that antigens, antibodies will obviously be produced. The name of the antigen for the current topic that I'm describing is called as SPEB. This is the antigen which is present on the surface of this bacteria. The full form of this SPEB, I'll write here also. It is called as Streptococcus pyrogenic. It is pyrogenic exotoxin B. Guys, what I'm trying to explain to you at the moment is post streptococcal glomerulonephritis. So some of the data that I state will be from pathology also. Streptococcal pyrogenic exotoxin B is that antigen which is present on the surface of this bacteria, and the antigen and the antibodies will combine with each other to form immune complexes. Once we get immune complexes from there onward, it's a problem because immune complexes now, once they're formed, they will activate the complement system. And what this complement system will do is it will start attacking the renal capillaries. Like in our glomerulus, we have fenestrated capillaries, and these fenestrated capillaries will be damaged. So because of the fenestrated capillaries getting damaged, the RBCs will now start coming in the urine of this patient much more than normal. Normally, it is like less than 3 RBCs per high power field in a centrifuge sediment. Now what is happening is that there is a type 3 hypersensitivity reaction that I'm describing for post streptococcal glomerulonephritis. You obviously would have guessed the name because I spoke about group A beta hemolytic streptococcus. So you can notice that now this immune system is going haywire. It is causing extreme amount of damage to the renal capillaries, because of which they will become leaky, and therefore the clinical manifestations of these patients will start anyway between 1 to 3 weeks later. What I mean by 1 to 3 weeks later is that there can be two possibilities. Either this person suffered from sore throat with this bacteria by the name of group A beta hemolytic streptococcus. The second possibility is that he suffered from skin infection. Like India is a hot country, so in the summer season, if somebody will not take a bath due to sweat and bacteria, there could be like pustules on the skin, that is pyoderma. So if somebody developed either of these two manifestations on day zero, if somebody developed any one of these manifestations on day zero, that is sore throat or pyoderma, about 1 to 3 weeks later, there would be classical manifestations developing in this person. That is, a immune complex mediated glomerulonephritis will damage the renal capillaries. That is why hematuria will occur. Instead of writing the word hematuria, because RBCs cannot survive in the urine, they'll burst, and therefore the description might be given of a cola colored urine. Make no mistake, initially when the urine is passed, then he will write the word smoky urine, but later when the RBCs will get destroyed, he might write the word cola color urine. So hematuria will be one of the initial manifestations of PSGN about 1 to 3 weeks later. Also, because the renal capillaries are getting affected, so GFR will also be less, because renal capillaries ke cross to filtration happens. So the capillaries are damaged, the glomerular filtration rate also drops. This activates the RAS system, and therefore you get a high renin hypertension, and therefore the hypertension kidney disease is already like always very severe and difficult to handle. So you will have to give ACE inhibitors to these patients. Now the next thing that will happen is that because the kidney is not functioning, the GFR of this patient is decreasing. Therefore, his wife is saying, this person's, that he was complaining of passing less urine, and then urine was not coming. So I suggested to him, like family member said, you drink more water. Weather is changing now. Somebody, you may not have passed urine because weather is changing, and like non-medical people are trying to rationalize their illness. So though the person has consumed a lot of water, nothing will come out because the kidneys are shutting down, because there's a obliteration of the Bowman space, as I explained to you in PSGN. So as a result of this, you would be having oliguria, anuria, and along with this, there would be puffiness around the eyes, as I've described multiple times in kidney damage. So there would be periorbital edema. Subsequently, there can be expansion of the plasma volume so severe that breathing difficulty can occur due to pulmonary edema. And by the end of the day, the swelling will appear on the feet of the patient. A person will become bedridden by this point of time. Then there would be generalized anasarca, but these are like the descriptions that can be given, like pulmonary edema, desaturation, shortness of breath, and then like the whole body of the patient is swelling up along with change in the color of the urine, that is cola colored urine. So the moment you read this profile in a young adult or maybe in a child, then we will say that we are dealing with post streptococcal glomerulonephritis. When we will be doing workup for these patients, some of the standard cliche information that would be given would be that on the urine microscopic examination of this patient, more than 100 RBCs per high power field were demonstrated. As I've explained to you, a single report is sufficient for confirming hematuria here. Apart from like the urine microscopic examination, the examiner will assist you by rating C3 levels in these patients are low, because complement system will get confused. He can also write the word RBC cast. Like I said, even if a single RBC cast is present, then we have to consider that as a possibility of like, hematuria. RBC casts always indicate, in fact, this itself is a pathologic question, that RBC casts indicate, your answer would be they always indicate glomerular bleeding. The C3 levels in these patients will begin to become reduced, and now the examiner will waste my time by describing that the blood urea nitrogen and creatinine is rising. He might give an ABG report in the question in which metabolic acidosis would be present. As explained to you in the respiratory system, the pH will be less. The person of metabolic acidosis will show small breathing, so PCO2 will be less and bicarbonate will also be less. So now the question will try to waste your time in the laboratory investigations. But then the core thing is, because the KFT is deranged, there is a hyperkalemic acidosis, I am planning to do a kidney biopsy. When biopsy will be done, the light microscopy of this patient, LM basically means light microscopy, will be revealing what I've already showed to you. I've showed you the glomerulus which was having those blue deposits. So I'm saying the word hypercellular glomerulus would be present here. It would be slightly inflamed also, so the size of the glomerulus will be bigger. And the most important thing that I've not written here, because already written, is that there is a complete obliteration of the Bowman space. As a result of this, there is like oliguria, anuria occurring in these patients. Additionally, sometimes the BP in these patients can become so high that it can cause a hypertensive crisis and even a left ventricle failure. So do keep a watch of that even uncontrolled BP in a kidney damage patient can result in hypertensive crisis and a left ventricular failure. Now, when you will evaluate the electron microscopy of this patient, he will say that there is subepithelial electron dense deposits with humps. Mark my words there. Earlier, I was focusing on the word spike and dome pattern for MGN, but at the moment, I'm talking about the humps which are present here. So I'll just deviate for a second and just go up to just highlight that slide to use, lest you forget it. That was subepithelial deposits with spike and dome appearance. A general question for you guys: can you tell me the drug of choice? I deliberately did not speak about it because in PSGN, we have to control hypertension mainly and manage the renal failure. But for patients of what is the drug of choice for management of patients of primary membranous glomerulopathy? The same MGN which was being discussed with antiphospholipase A2 receptor antibody, which was called as PLAR. Antiphospholipase A2 receptor antibody, PLAR antibody, is seen with primary MGN. There you don't need to do a kidney biopsy also. But like, what medicine will be used here? So your answer would be an anti-CD20 molecule, that is by the name of rituximab. Just like I taught you for minimal chain disease. Just like I taught you that for minimal change disease in a patient, I will give steroids. Here it will be rituximab. And if a person is having primary variety of focal segmental glomerulosclerosis, then again I will be using steroids in higher dosages. And if required, I might even add tacrolimus to manage these patients' proteinuria component. At the moment, you know drug treatment for three of them. Minimal chain disease, it is spironolactone with steroids. For primary membranous glomerulopathy, it is rituximab, and for primary focal segmental glomerulosclerosis, it is steroids with tacrolimus. What do you do for secondary? Treat the cause, no? Like, suppose if it is secondary focal segmental glomerulosclerosis, like the one that I told you are secondary causes, HIV, nephropathy, treat HIV. If it is VUR, go for ureteric reimplantation. If it's a heroin abuse, then we have to send him to detox clinic. Pamidronate, we can switch to a different drug. So my point is, for secondary focal segmental glomerulosclerosis, it is a cause-specific treatment. But I just wanted to introduce these drugs here in between, because now I'm going to be talking about even patients of PSGN, post-streptococcal glomerulonephritis, who would be requiring ACE inhibitors and would be requiring Lasix because the kidneys are shutting down. Like, don't wait for like immunofluorescence image to be given to you, where you will be able to pick up the starry sky appearance. I mean, even if the starry sky appearance is not given, the description that I've given of a child or a young adult or a teenager who comes to us with the following profile, then we have to think in terms of PSGN, that is post-streptococcal glomerulonephritis. So what I've described in this slide is one of the formats of nephritic syndrome, that is called as PSGN. Let me just write down the name here also, post-streptococcal glomerulonephritis, that is the GN word. I'm just writing just like that. And this is an example of type 3 hypersensitivity, where the clinical manifestations will not develop immediately, but will be developing something like about 1 to 3 weeks later, with renal shutdown occurring in this person, and along with that like the whole body is beginning to swell up. So I decided to do a basic workup. On the workup of this patient, what I found was some very interesting observation. Obviously, like the hematuria part is gonna be given, cola color urine will be given, RBC cast will be given. But what is important is to pick up that in this condition, C3 levels will be less and complement system is consumed. But this is a transient decrease in the C3 levels. So this condition will not usually get converted into CKD. It can get converted, but usually will not get converted into CKD. And meanwhile, like the kidney biopsy is obviously the main investigation that would be done for post streptococcal glomerulonephritis. So now help me out. I would like you to cooperate with me here and tell me which antibody against Streptococcus bacteria is causing trouble here. Like in the options, there was anti-streptolysin O antibody and anti-DNA ACE antibody. Your answer would not be given as anti-streptolysin O because ASO antibody is seen in rheumatic fever. So here your answer would be anti-DNA ACE antibody that would be present. So if I summarize the workup, that's the core thing. We have done a urine routine. Then we have checked the complement levels. We have evaluated the KFT with the APG. We've done a kidney biopsy in this patient. And then like while I'm trying to find the etiology, I've done an anti-DNA ACE antibody also. Remember, this antibody is the incriminating antibody which causes immune complex formation, and then type 3 hypersensitivity reaction will be occurring in these patients, resulting in manifestations of hematuria with hypertension. And even in this condition, guys, don't be surprised that he might mention proteinuria, though the magnitude of this proteinuria that is present in this case would be subnephrotic because blood is coming in the urine. So even in these patients, proteins will also be coming. So don't be surprised that in PSTN, if he mentions that urine protein has been found, but obviously the magnitude of this protein will not be like more than 3.5 grams per day. This would be a subnephrotic proteinuria that is present. So if I just highlight the statements that I made before you, in nephritic syndrome in a patient, you'll be getting the following manifestations. The first and the foremost is that there is a change in the physical appearance of the urine, that is hematuria, which can be written as cola colored urine. The second would be that there is a development of hypertension, which can be severe enough to contribute to pulmonary edema or like hypertension related complications. And the third one is obviously proteinuria. Now, he may not write the word like subnephrotic proteinuria. He may quantitatively write the value there. The subnephrotic range proteinuria, as I've explained to you, would be a value between 1 to 3 grams per 24 hour in a timed specimen. We can do spot sample also, dipstick no, but it would be then 3 plus or maybe 2 plus and would not be 4 plus most of the time. So nephritic syndrome that I described before you, there can be manifold causes for it, but one of the common causes that I've described is called as PSGN, where starry sky appearance on a kidney biopsy is obviously cool thing to remember. But then what you need to remember is that even if amylofluorescence is not given, the word subepithelial electron dense deposits with humps and then hypercellular glomerulus, as I explained to you, with complete obliteration of the Bowman space, is the core thing that we will use to identify PSGN, post-streptococcal glomerulonephritis. The hypertension in this condition can be severe enough to contribute to pulmonary edema, so bad that patient may require hospitalization. So for reducing the pulmonary edema, we might have to give nitroglycerin to control the spike of blood pressure of this patient. In nephrotic syndrome, it was all O's present. Here it is the I's that I've described to you. And now I will also mention one of the important aspects, because electrolyte imbalances will occur in these patients. So hyper and hypokalemia, ECG changes and treatment will be discussed. The ECG finding of hyperkalemia has been elaborated even earlier, but I'll just do a quick practice with you. I'll try to take it lesser amount of time here because this is discussed already, but just a quick revision anyway, since we are doing it, or you might have attempted the video the first time and without touching the cardiology component. So in hyperkalemia, first the height of the T wave will tend to increase. So the initial finding that will be occurring in this patient is presence of tall tented T waves, which should not be mixed with hyperacute T waves or myocardial infarction. After a tall tented T wave, the second thing that you will come across would be ST segment will be following the T wave. So you'll get a ST segment elevation. The third finding is that the vertical height of the first wave of the ECG will begin to become smaller and will disappear. And because potassium will tend to slow the depolarization current in the bundle of phase or in the Purkinje network. So because I said the word slowing of current conduction in the ventricular system, so the QRS will tend to get spread out. That is, broad QRS would be present. That's more than 120 millisecond. Now mentally visualize, first wave of the ECG will begin to disappear. The QRS complex of this patient will tend to become more broad and the T wave is going up. So what I'm saying next is that this broad QRS may actually merge with the absent T wave, and you might get a very peculiar pattern which is called as sine wave pattern. We don't read like this, does not look like an ECG. Now the ECG will have those squiggly lines of P, Q, R, S, T, but this is like a totally peculiar pattern that has been introduced the first time. This pattern that I've explained is called as sine wave pattern, and this is just a few minutes away from where the person can die because of cardiac arrest. Most of the time it would be a diastolic cardiac arrest. Why diastolic? Because potassium is gonna relax the heart. Calcium causes contraction, potassium will relax the heart. Now we will compare this finding with that of hypokalemia. I just need to invert the language. In hypokalemia, because potassium is going down, so what you will notice is that the T wave will follow like the vector with respect to hypokalemia, and the T wave will become negative, that is upside down. Normally T wave is always upright. So one of the finding that you'll be always getting in these patients is presence of T wave inversion. That's one of the important aspects. T wave inversion is seen in hypokalemia, and ST will always follow the T wave, so there would also be a development of ST segment depression. And now the reverse will happen, that the height of the P wave in this condition will begin to start increasing. So the term that's used to describe this increase in the height of the P wave is what is called as pseudo P pulmonale, because P pulmonale is what you traditionally read with like a right-sided enlargement in a patient due to tricuspid stenosis, but here it's like a pseudo because it's not a cardiac chamber enlargement but a ECG based finding. Then a new finding will appear here, that is in the form of a prominent U wave. Now we read about U waves, that's okay. I mean, normal person's ECG also U waves can be there, but here the word would be a prominent U wave, or in some questions he may write the word prolonged QU interval, because traditionally we read the word prolonged QT interval. So what I've described at the moment are ECG findings of hyper and hypokalemia, especially with respect to the one that I've currently described, pseudo P pulmonale, prominent U waves, and prolonged QU interval are some of the like the comparison based data that is to be remembered, especially the three datas in red. Now my main focus will be from the kidney perspective. So because my patient can develop arrhythmias, I would like to treat my patient aggressively. For the treatment of hyperkalemia, the first thing that we'll do is give IV 10% calcium gluconate. Calcium gluconate is used because it is an antagonist of potassium. Potassium relaxes the heart, calcium will contract the heart. The next intervention that you will do after this would be to give the person insulin drip. This insulin drip would be a regular insulin, as I've explained to you in the endocrine section also, that in emergency we always use a regular insulin. This would be fast acting as well. We'll give it intravenously, and what it will do is it will send potassium inside the cells. This insulin drip is usually made in 25 to 50% dextrose. That's understandable because we want to prevent the development of hypoglycemia. And when we give this regular insulin drip to the patient, then the advantage is that the potassium will start going inside the cells. Calcium gluconate does not cause a fall in potassium. Calcium gluconate is only given for antagonism, but here when you give insulin drip, the amount of fall that you will be getting is in the range of about 0.5 to 1 milliequivalent per hour. So even if the value is at the moment 6.57, over the next 2-3 hours, I can decrease the value to a decent value of 3.5 to 5.5. The next thing that to be used after this is salbutamol nebulization. This salbutamol normally we read for like asthma. So like when I describe it, the students are like, sir, are you serious? Salbutamol is for asthma. You're saying it for person with hyperkalemia. Yeah, because salbutamol also causes potassium to go inside the cells. Redistribution. Then I can give Lasix to the patient because I'm dealing with a renal case. The advantage of Lasix and furosemide is it will contribute to caliuria, that is a urinary loss of potassium, and I'll be able to like bring down the potassium values to respectable levels. And if I am like having a refractory hyperkalemia, I've done all of these aspects that I have currently explained to you, and still the patient's potassium values are elevated, then I can go ahead with hemodialysis for management of these patients. So the steps are calcium gluconate for antagonism. That's the drug of choice to be answered, but don't answer it if he says which drug will cause lowering. I've already explained to you that if it comes to the concept of lowering, then we will be giving insulin drip to this patient. That would be mixed with 25 to 50%. Dextrose, the magnitude of fall is about 0.5 to 1 millicurrent per hour. Salbutamol and insulin drip, the two molecules that I have just marked at the moment, both of them cause redistribution, whereas Lasix is the one that will be causing caliuria. And then we can, for refractory hyperkalemia, use, refractory hyperkalemia, hemodialysis can be used. One more question I can add is, which of the following is not routinely used in management of hyperkalemia? The language of the question is very peculiar. The question says, which of the following is not routinely used? Normally we read about like the common drugs, no, like the one that I've explained to you. But if he changes the language of the question and says not routinely used in hyperkalemia management, then your answer would be soda bicarbonate. Soda bicarbonate would be used if there is a concomitant metabolic acidosis present. Then I'll add soda bicarbonate. Otherwise, not routinely used in hyperkalemia management is the molecule that I've just mentioned, soda bicarbonate. For hypokalemia, obviously, we shall be giving to this person KCl drip. Potassium will never be given directly in a central line because it can cause a development of cardiac arrest in a patient. But yeah, hypokalemia, if I want to treat, then I will give KCl infusion to the patient. That will cause a gradual rise of potassium in the body of these patients. So ECG changes in electrolyte imbalance and kidney disease is what I've tried to highlight at the moment, including the drugs which are used. Then a couple of miscellaneous findings once again before we focus on the core aspects. Like this is one of the famous questions where it looks like a head of a cobra, that is a adder head or a cobra head appearance of the terminal part of the ureter. So this question is like a bonus if it comes, that is ureterocele. The second one is again important because the kidney is appearing totally calcified. So don't answer it as Stagon calculus. This is like a putty kidney that could be seen with tuberculosis. It's just like a total shrunken, I can say autonephrectomy will be happening here and the kidneys will totally shrink in size. But if he wants to give you a struvite stone, that Stagon calculus, it will be like ginger, no? Like it is having these protuberances that you can see. It's just literally taking up the shape of the kidney. So what I can see in this patient in the X-ray KUB is a struvite stone. So these are like couple of those spotters which I wanted to bring to your attention on X-ray KUB. And then they've asked urine microscopic examination where we could be having calcium oxalate crystals. The most common cause of hematuria happens to be kidney stones. And the most common type of kidney stone, happens to be calcium oxalate. This calcium oxalate is again of two varieties, calcium oxalate dihydrate and monohydrate. So remember COD, cash on delivery. Like if cash on delivery is occurring, it occurs in an envelope. So you can see these envelope shaped crystals which are present here for calcium oxalate crystals. But if he says the word calcium oxalate monohydrate, not COD, COM, then the crystals which are present here would be shaped like a dumbbell. So there are two terms that I want you to remember. Code, I think it will be sufficient for you to remember that cash on delivery in an envelope shaped crystals are seen with calcium oxalate dihydrate. But if I change the language of the question, or if I give an image to you where there's a dumbbell that is appearance present, that dumbbell appearance or dumbbell crystals would be a feature that is seen with calcium oxalate monohydrate. Let's do it again, CODE and COMD. So dumbbell appearance of the crystals versus the envelope shaped crystals. And then they might ask you regarding a very hard kidney stone. The hard kidney stone is called as cystine stones, which would be seen with cystinuria. In this particular case, the crystals will be having a very six face appearance. So it is a hexagonal crystals that would be present. And while I'm writing this, I'm putting up an open question to you because this is taught in pathology, but I'm just covering here is that what finding would you be getting in struvite stones from the crystal perspective? If you do a urine microscopic examination of these patients, then the crystals that would be present would be having what is called as a coffin lid appearance. So additional points that I've added, but I've not shown an image of. The three common images are what I've highlighted. Just be careful for calcium oxalate monohydrate versus that of dihydrate because the interpretation can change with respect to the shape of the crystals. And this is like unlikely to be asked because you will be anyway answering it. This is a coffin lid appearance. The reason for struvite stone is infection with Proteus species or Providentia. Like Providentia, earlier I was blaming for that purple discoloration of urine. Now I'm blaming it for like struvite stone because this causes alkaline urine. alkaline pH of the urine, and this alkaline pH will cause precipitation of crystals that will cause triple phosphate stone. So you guys quickly tell me from your knowledge of pathology, what is the composition of triple phosphate stone? We call it struvite stone, we call it Stagon calculus, or we can just use the word triple phosphate stone. So the composition here would be magnesium, ammonium, and phosphate. Yes, guys, the composition of this struvite stone, which takes up the shape of the entire kidney, the composition would be like magnesium, ammonium, and phosphate. These crystals will like gel with each other and they form this outline of the shape of the kidney. That's because of the alkaline pH. At this moment, another FMG question I can squeeze in: which of the following kidney stones will not be affected by urine pH? Then it is calcium oxalate. Calcium oxalate is pH insensitive. Calcium oxalate, the most common type. One more question squeezed in for calcium oxalate stone, that this is the pH insensitive stone, because like in uric acid stones, it is acidic environment or it can be alkaline environment for like Proteus species. But a pH insensitive kidney stone should be remembered as calcium oxalate dihydrate, and this would be having envelope shaped crystals, as we remember from the mnemonic code. Now we comes to an awaited topic, renal tubular acidosis. One RTA1 is famous because this is asked for association with Sjogren syndrome. Even in rheumatoid I've described it. And second is association with amphotericin B. Last time I mentioned amphotericin B, I said that this can contribute to like renal failure, and it can cause a non-oliguric type of renal failure. Now, what is the problem in renal tubular acidosis type 1 is that the hydrogen cannot be excreted and potassium cannot be reabsorbed. Like there are alpha intercalated cells which are responsible for excretion of hydrogen. So this action of hydrogen loss in the tubule will not happen. And I'm trying to oversimplify the diagram by showing a hydrogen potassium ATPase apart from alpha intercalated cells. This is responsible for reabsorption of potassium. And now I'm putting a cross to say that due to Sjogren amphotericin B, if this potassium hydrogen exchanger or potassium hydrogen ATPase will malfunction, then hydrogen will not be excreted. The word will be inability to acidify the urine because hydrogen cannot be excreted. And the urine pH of these patients will always be more than 5.5. So we're going towards alkaline urine, and that's why there is a metabolic acidosis. Also, you can see that in these patients there is a impaired function of this hydrogen potassium ATPase. So you will say that there is a inability to absorb the potassium. This potassium is not getting reabsorbed. There is a kaliuria that is happening, and that is why there is a hypokalemia component. Hyperkalemia is a feature of type 4 RT. I'll give you the reason, but here it's a hypokalemia. And then because the condition is also associated with low urinary citrate and alkaline urine, so the combination of the two increases the risk of kidney stones. That would be nephrocalcinosis. We don't get nephrocalcinosis with any other variety of renal tubular acidosis except the one that we're discussing. And because they cannot excrete hydrogen, that is why these patients would be having is a presence of normal unengaped metabolic acidosis. If you just focus on this line diagram that I made before you, things will become obvious that why there is a acidosis, because hydrogen is not getting kicked out and the urine pH is going towards 5.5 or more. That's primarily because of like inability to acidify the urine. This has been asked in NEET PG. He gave a scenario of a Sjogren patient and he said urinary pH is 9.4. So I mean that would happen only with RTA1, and there was a hypokalemia that was also described. So the mnemonic is alpha can't acidify. There are special cells here that are called as alpha intercalated cells in the distal tubule of the kidney. This disease affects the distal tubule. There are special cells called as alpha intercalated cells. They excrete hydrogen, so they are also defective, and the hydrogen potassium ATPase both are not working. So there are two cells which are being affected here. One is the one that just excretes hydrogen, that is alpha intercalated, and second is the hydrogen potassium ATPase, but that makes it life relatively easier for type 1 caused by Sjogren and amphotericin B. When it comes to type 2, then the causes to be remembered would be Fanconi syndrome, Wilson disease, and then multiple myeloma. In multiple myeloma, it's the Bence-Jones proteins that are causing damage. In Wilson disease, it is copper which is causing damage. So let us just look at like where will this damage be present and how will it manifest. So the damage in RTA type 2 is seen in the proximal tubule. Therefore, the highlight of this condition is bicarbotonuria. We will not read this word anywhere else in medical literature except for bicarboxylurea. Word is described for renal tubular acidosis type 2, and because you're losing alkali from the body, because alkali is reabsorbed from the proximal tubule, and if alkali will not be reabsorbed, bicarboxylurea will be occurring, which will cause subsequently urine bicarbonate to be on the lower side. Additional thing is, from the proximal tubule, salt is also absorbed. From our proximal tubule, salt and water both are absorbed. So if salt will not be absorbed, it will be like if you lose salt from the body, then body will try to compensate by releasing more aldosterone. And if the body will try to compensate by releasing more aldosterone, then aldosterone causes rather potassium loss in the urine, and therefore hypokalemia will occur. This I've explained in endocrine, so I don't need to draw the diagram. That because in this condition, proximal tubule causes mainly salt and water absorption apart from bicarbonate. So because salt is getting lost from the body will try to compensate for that by increasing the amount of aldosterone production. And the disadvantage of that aldosterone production is that it causes a kaliuria as well as hydrogen loss. So there would be like hypokalemia occurring in this patient. That hypokalemia is explained because of the hyperaldosteronism present here. The causes of this can be Fanconi's, Wilson, and multiple myeloma. In fact, Fanconi's is the disease where additional findings can also be present. So what I write next is specific to the description of Fanconi's syndrome, that here additional findings would be given. Let's just practice those additional findings also. The first one to be remembered for Fanconi's is that apart from glucosuria, he may say the word amino aciduria or phosphaturia, because multiple other products are also affected in Fanconi's syndrome. Don't mix this topic with Fanconi's anemia. That is going to be aplastic anemia, totally a separate thing. It is Fanconi's syndrome where glucosuria, amino aciduria, phosphaturia, bicarboxylurea, those are the kind of like the urea word written for various products which are absorbed from the proximal tubule, that would be given. Then is type 4 RTA. Type 4 RTA is caused due to diabetic nephropathy. Now, diabetes will damage the juxtaglomerular. Diabetic nephropathy implies that the kidney parenchyma is damaged. So this would result in juxtaglomerular apparatus getting destroyed. So aldosterone production will become less. And also in diabetic nephropathy, kidney tubule, where aldosterone acts, the epithelial sodium channel is also affected. So it's the two things in this patient. That is why they write the word pseudo hypoaldosteronism here, because if the juxtaglomerular structure is damaged, so that will contribute to decreased production of renin. And along with this, like renin production being lesser, I said the epithelial sodium channel, the area where this is present, this is also gonna be like damaged. So epithelial sodium channel resistance can be present. In fact, better way to put is, one, the JG apparatus is gone, so renin is less. Second, because the tubules are damaged, so there's a epithelial sodium channel resistance occurring in this patient. And how does epithelial sodium channel operate is what I've discussed in endocrine, but I'm gonna do it once again before you. It is responsible for gain of salt and water. So now salt will not be absorbed and water will also not be absorbed. But along with that, what will happen is that potassium and hydrogen excretion will also be impaired. I'm just putting a crossover to say that because I said the word resistance, so salt and water are not getting absorbed, understandable, but there is an inability to excrete hydrogen and potassium, and because hydrogen cannot be excreted, that is why there is a hyperkalemia with inability to acidify the urine. There is a hyperkalemia with inability to acidify the urine. The data is that in RTA1 you get a hypokalemia, and RTA2 you can again be having hypokalemia present, but RTA4 will always be having presence of hyperkalemia. The reason why in RTA2 there is like hypokalemia, I can just say verbally, is again because in proximal tubule salt is also absorbed. If salt is not absorbed, that salt loss will cause more aldosterone. More aldosterone will then cause potassium loss and kaliuria happening in a patient. So kaliuria contributes to hypokalemia in both RTA1 and 2, but potassium is elevated with respect to RTA4. That's like the description in a single slide for the manifestations. Let's do the slide again without having access to it. If I focus on the word RTA1, the important causes Sjogren syndrome. That's the first priority, followed by amphotericin B. Just keep that mental image of hydrogen potassium ATPase. So there's inability to acidify the urine and hypokalemia. In RTA2, the keyword is bicarboxylurea, but because Fanconi syndrome can be associated, so glucosuria, amino aciduria, phosphaturia, all those things can be given in the question. And in RTA4, it is a aldosterone resistance and decreased production of aldosterone, decreased production of renin first, and therefore aldosterone production is also less. So that's why he will say the word pseudo hypoaldosteronism, because traditionally we read the word hypoaldosteronism in Addison disease. But today I'm not teaching you Addison, I'm teaching you pseudo hypoaldosteronism, because one, renin production is lesser, second, epithelial sodium channel resistance is occurring due to tubulointerstitial fibrosis, and the rest I can say is history, because potassium is not getting excreted, so hyperkalemia with metabolic acidosis. In all the varieties of RTA that I've described before you, by default we'll always be having we will always be having a normal anion gap metabolic acidosis. All of them cause a NAGMA with potassium values which can either be elevated or potassium values that can be reduced. So for where do you get potassium to be elevated? RTA4. Potassium can be less in RTA1 and 2. And how to differentiate 1 and 2 is then check out the kidneys. If there is kidney stones developing, then it will go in favor of RTA1. So I said NAGMA with hyperkalemia, RTA4. With hypokalemia is RTA1 or 2. To differentiate between 1 and 2, if he says S-Jogren, things will become easier. If he says Wilson disease, things will again become easier from the etiology perspective. Lots of time he will not say etiology. So between 1 and 2, what you need to remember is, how to differentiate them is one with respect to either the word bicarbonate or in RTA1 there is a nephrocalcinosis. So I'll just write a short form and erase it here. Nephrocalcinosis with RTA1 is present. And in RTA2, I said it is Fanconi's anemia manifestation, Fanconi's syndrome manifestations that would see that error came, no? Fanconi's syndrome manifestation that will occur. This is not Fanconi's anemia, which is a congenital aplastic anemia. These last 2 points in short forms I'll remove here because they'll cause unnecessary confusion, but the remaining data, in my opinion, looks very straightforward. Now I will describe a couple of electrolyte imbalances before you. So you know that for hyponatremia, we never do a fast correction. If we do a fast correction, it can cause stroke-like manifestations, including locked-in syndrome. So the correction should always be done very, very slowly over 24, 48, maximum 72 hours. Fast correction of chronic hyponatremia results in osmotic demyelination syndrome. Earlier, the term used here was central pontine myelinosis, but now we say the word osmotic demyelination, and the symptoms appear after 48 hours with the confusion, disorientation, and then frank locked-in syndrome and cranial palsies can develop because brainstem gets involved predominantly, and the radiological finding is called as trident sign. Let's do a question to see you got me or not. This is a 28-year-old guy. He collapsed at the at the finish line of a marathon in hot weather, and he had a GTCS, and you can notice that in the workup sodium values are 118, though vitals are fairly decent. Now, because he consumed a lot of water during the race, dilutional part can contribute to acute onset hyponatremia, and this acute onset hyponatremia is causing dangerous hyponatremia because the sodium values in the patient are less than 125. This is the threshold of dangerous hyponatremia, so sodium is very, very low. So what should I do in this particular case is I can give a bolus of 3% saline, and if I increase the values to something like 122, 123 gradually over the next couple of minutes, like 10 minutes or so, I'll be able to stabilize the patient. When I describe like this, the query of a lot of students is, sir, you yourself said that correction should be given very, very slowly. You must appreciate it is not for acute onset hyponatremia. It is for chronic onset hyponatremia. Fast correction of chronic hyponatremia causes osmotic demyelination syndrome. If a person is having acute onset hyponatremia and is causing seizures or is having GTCS, we just need to give hypertonic saline to the patient, and we increase the sodium by a few points, and that will help in termination of an episode. So only if we will mention the word like chronic hyponatremia, or I'll give you a description, that the third answer is valid. Let's do the next one. Smoker presents with fatigue, headache, and increasing confusion, including loss of weight. So he's trying to tell you regarding a possibility of a malignancy, because he's talking about like a smoker. There's a lung mass. There is he says the patient. Okay, X-ray shows a hilar mass. So right hilar mass in a smoker indicates a possibility of a malignancy along with loss of weight also. And then he says that sodium is very low. That's why he became disoriented. So this particular question is on the topic of SIADH, which is seen with lung cancer, and he's talking about chronic hyponatremia. If he himself says the word lung cancer, cool. But otherwise you have to link up the data, smoker, weight loss, and my higher mass. So I will think in terms of a lung malignancy, that is oat cell cancer of the lung. This can cause a ectopic synthesis of antidiuretic hormone, and what antidiuretic hormone does is it will absorb more water. More water will cause dilution, and therefore chronic hyponatremia can cause seizures in this patient. Here you will be doing a slow correction, and it should not be exceeding more than 6 to 8 milliequivalents per 24 hours. So for acute onset hyponatremia, no restrictions like these, but for chronic onset hyponatremia, though, you have to do a slow correction. Then he has made us calculate like the formula for correction. So formula for correction is total body water into desired value minus the actual value. Like in this patient, the actual value to be given is 120. So I want to increase by 6 points, that is 6 milliequivalent is the safe value here. So I want to upgrade to 126 from a value of 120. Desired value is 126, raised value, actual value is 120. How do you calculate total body water? Is you have to multiply weight. Like in this case, he has mentioned, I think, the gender. 50-year-old patient, lung cancer, develops seizures. Okay, so we'll take him to be a male patient, 55-year-old patient with weight of 60 kg. Gender is not given, but we'll assume that lung cancer patient must be a smoker, and like weight is 60 kg. So if I take like weight into 0.6, for men, it is like 60 into 0.6 into 6 only. My mathematics is bad, but I think we will still be able to figure out the data. If it was a female patient, I'll just read it again if there's any female description given. No, there's no gender given. So we're taking like male smoker, and if for mathematical calculation I take it, it will turn out to be 180 milliequivalents. So I will give the lowest possible correction. Then I also want to bring your attention to the fact that when I'm saying the word lung cancer, this person is having SIADH due to a query. I mean, okay, not a query, diagnosed case of lung cancer is mentioned, and the reason why there is a development of hyponatremia is because water in the body is more. In fact, the condition that I'm saying, SIADS, total body water is more, but total body salt is normal. When you were listening to my discussion on like the earlier part, I said water and salt both are more with aldosterone, but with antidiuretic hormone, it is only water that is more. So that will contribute to a dilutional hyponatremia. And therefore, in these patients, like the values can be low enough to result in development of seizures. So serum sodium is low. And because in SIDH, all the water will come back in the body. SIDH is a condition, antidiuretic hormone is more. Water will come back in the body, so it will make the plasma of the patient or serum of the patient dilute. So the word low here means that it will be dilute plasma. Urine osmolality and plasma osmolality always have an inverse relation. So if urine will be dilute, the plasma will be concentrated. You can imagine like this, that in patients who are having SIADH, all the water is coming back in the body. So urine will be very concentrated. So that's what I've written, urine osmolality will be high. Now, because there is more water in the body, there is another hormone that is liberated by the name of atrial natriuretic factor, and due to the release of ANF, these patients' urinary sodium would be high. This is an important point to be remembered from MCQ perspective. Urine sodium was low with respect to the pre-renal variety of acute kidney injury. Now I'm teaching you urine sodium will be towards the higher side, more than 40 with respect to SIADH. The reason is liberation of due to liberation of atrial natriuretic factor. The volume status in this condition is euvolemic. Don't answer hypervolemic. In hypervolemic, salt should also be more and water should also be more. Whereas in this case, it is only and exclusively the water component that will be relatively more. The salt in the body is normal. The mathematical calculation that I've done here before you is on basis of total body water. You should be aware of the fact that I'll use a separate color for this. For men, total body water is a product of weight into 0.6. For females, the total body water is weight into 0.5. Well, how to remember it? I can say women have more fat in the body and men have more women have more fat in the body and men have more water in the body. So 0.6, so men have more water in the body. That's why. So this mathematical calculation was done on the basis of this formula. total body water into desired value minus the actual value. Mark my words there. Desired value is always 6 point more. So suppose the value was given 110, I'll increase to 116. If it was 116, I'll increase to 122. So don't worry about desired minus actual value. Just multiply by 6. Whatever is the total body water, guys, whatever is the total body water, just multiply it by 6 and you get the answer for the correction to be given in the next 24 hours. The important thing here is next 24 hours. If he says total correction over 3 days, so then the target value will be 120, 126, 132, going up to 138. So because I want to increase over like 18 points increment, then I'll multiply by 18 point increment, then I'll multiply by 18 into 30. Like if I take for easier calculation, then answer will go towards like like between 500 to 600 range. So the message at the moment is it is next 24 hours. We don't, in chronic hyponatremia, we don't go for fast correction. We don't go for total correction. We go for only a partial correction happening over 24 hours. That is why in this question, the value is coming low. Why? Because the desired value is not 135. Normal is 135 to 145. Now I could have taken a desired value 135 also, but I want to increase only by 6 points. That is why I have highlighted this total body water. How do you calculate? Data in front of you, and multiplication factor in this case would be 6 units only. If he says total, yeah, I want to increase to from 6 to then 12, and then from 12 to another 6 maybe, and I can upgrade to about 140. Urinary sodium is more in patients of SIADH and is less in patients of prerenal variety of acute kidney injury. Now I'll teach you regarding hypernatremia. So what is dangerous would be a value more than 158 millicoulomb, and just like in hyponatremia, we have to raise the value slowly. Here the value of sodium has to be brought down, but again slowly. Again, there is a risk of fluid shift across the brain, so the standard values would still apply. Just like in hypernatremia, I was saying that I need to cause a sodium value to rise by 6 to 8 millicoulombs. Here I want to cause a fall by 6 to 8 millicoulombs per day, for which I will have to give fluids to the patient. The formula for calculating this fluid is right in front of you, so we just need to deploy this. This is a 60 kg man, because he's saying the word man, so I'm multiplying this by 0.6. The current sodium in the body is, let me say, okay, the value is 160 and the denominator is 140. That's the target I want to achieve over next about 3 days or so. So if I divide this, this would be 36 into some mathematical value of about 1.1 approximately. So if I do this mathematical calculation, you will notice that the value will not be coming in round values like 2 or 3 anyway. I mean, these two values are ruled out. And like if I multiply 36 by that 1.1 or something, it will turn out to be in the range of 4.3. Honestly, I had to use a calculator to solve this. My mathematics is really bad. But then as I have explained to you at the moment, the mathematical correction that we are doing for this particular case is not to be given over the same day. It is over the next 72 hours that this fluid deficit or water deficit needs to be given to this patient. And usually like hypernatremia occurs in geriatric age group patients. Now we will just summarize the important electrolyte imbalances that we have discussed. So I'll try to do it faster. Hyponatremia is usually values less than 125. The possible reason why patient can fall sick or can die is because of seizures, because in seizures patient is not in senses, so they can aspirate. For hypernatremia, the value is more than 158 millicoulombs. Again, the reason is seizures. The fluid of choice, however, will change. If he says what is the fluid of choice for hyponatremia, then it is hypertonic saline. And for hypernatremia, I will be giving to this patient either N by 2 and 5% dextrose if feasible, or even if that N by 2 and 5% dextrose is not available, I can be giving 5% dextrose for management of these patients. The correction has to be done slowly. Rise of hyponatremia by 6 to 8, fall of potassium sodium again by 6 to 8 millicoulombs. And osmotic demyelination syndrome is a complication that we see with mainly fast correction of hyponatremia. Fast correction of hyponatremia is only to be done in acute and not in chronic, as I explained to you. Hypokalemia, the main reason why patient can die is diaphragmatic paralysis, because if potassium in the body is less, then muscles will not be able to function. So I need to give KCl to the patient in the form of a drip, never give it in form of a fast infusion. And this KCl drip calculation will be told to you in like about another 2 minutes from now. For hyperkalemia, the usual cause of death can be a cardiac arrest. Most of the time, potassium will slow down the heart. So there is a diastolic cardiac arrest that is occurring. And in these patients of diastolic cardiac arrest, I can say that the drug of choice, that's the main intervention that would be used, is IV 10% calcium gluconate. In fact, this IV 10% calcium gluconate will be the answer two times, one for tetany, that is hypocalcemia, and second is for hyperkalemia. In tetany, however, the cause of death turns out to be laryngospasm, right? It is not laryngeal edema. Laryngeal edema is what you read with anaphylaxis. Then for hypercalcemia, that is discussed with lung cancer. In endocrine section for hypercalcemic crisis, the cause of death can be a systolic cardiac arrest in a patient. So we can have a diastolic cardiac arrest with potassium, because potassium relaxes and calcium causes contraction. For hypercalcemia, the drug of choice would be bisphosphonates. I can give calcitonin also, fast acting, but then calcitonin has that tachyphylaxis and there's a tolerance happening. So I can be giving like a bisphosphonate that can be given intravenously, like ibandronate or zoledronate, for management of these patients. Then hypermagnesemia is when values would usually go in excess of like 10. That's when patient can have cardiac arrest or neuromuscular paralysis. And this is the third time that 10% calcium gluconate will be used. So most of the time the scenario given will be that the patient was given Pritchard regimen, eclampsia management, and after that the blood pressure of the patient started to fall. Patient started developing bradycardia. That's because of excess magnesium given to a patient. But in hypomagnesemia, it can be arrhythmias like tositis, D pointus, and tetany that is occurring. And here, obviously, we need to give magnesium sulfate for management of these patients. So the fluid of choice is what I've highlighted at the moment before you. And now, like I can say that that one 10 ml glass ampule of KCl that is available, that one ampule contains 20 millicoulomb of potassium. And when I give it to the patient diluted, added to the bottle normal saline, then it can increase the potassium in the blood by 0.25 millicoulomb per liter. So like he's mentioned a patient whose original value was 2. So if potassium is 2, then the target that I want to achieve in the next 24 hours with my correction is about 3 millicoulomb. We don't increase to like more than 3 with IV correction. From 3 to 3 from 3 to 3.5 I can increase with oral pot chlor, but 2 is like a danger because patient can develop a possible like respiratory paralysis. So I want to increase to 3 points. Now I'm doing mathematics. 20 millicoulombs will cause a rise by 0.25, so 40 will cause 0.5, that is 2.5. Then if I give another ampule, the third ampule, I'll increase to 2.75. If I give the fourth ampule, that would be raising up to 3. So the total, like the KCl correction that I need to give to this patient is 80 millicoulombs of KCl. This 80 millicoulombs of KCl will be now added to the IV fluid bottle and would be given slowly to this patient over the entire 24-hour period. And I would not be giving it, rushing it, preferably like in emergency. Yeah, if the person had values so less that he was literally having a respiratory insufficiency and saturation was falling, I could have given a fast correction. But here, like via center line, but here, like I have 24 hours at my disposal, so I will add it to the bottle of IV fluid. I'll do the mathematics once again. 1 ampule causes like rise by 0.2 millicoulombs to 0.25. So mathematically to increase from 2 to 3, I need 4 ampules, that is 80 millicoulombs of KCl needs to be given to the patient. These calculation wala questions are not asked in FMG exam. They are asked in NEET PG in any set, but I still have to discuss them because I want like every one of you to be prepared for any kind of exam that is asked. These mathematical based questions can be skipped by those who are sitting for FMG exam. Don't bother about them. But yeah, the remaining part without the theory part, like what is the fluid you will give, that they'll ask you. So these are the technical aspects for like the kidney topic, guys, that I have discussed in front of you. And like it took time, but then I have tried to cover like those core aspects which are asked. And yeah, I mean, it was a discussion where like lot of like logic was tried to be emphasized, because kidney always follows logic and rationale, and that's why it is able to maintain the balance, as I was saying. Otherwise, like the human body just goes crazy once the values tend to go off the radar. These are the technical details, guys. Keep the pressure on, keep learning, and like I see you on the other side. But a word of caution is that the persistence is the key. Just like you are listening to me non-stop, and I'd recommend like non-stop video lectures, because that's the only way to finish it, get the monkey off my back kind of an approach. And like if you do it in ifs and bits, then usually like the time utilized in study becomes so much that one tends to lose track of like what were you reading, right? Then you tend to get bored with the subject, move on to the second one. So I think like bulk, cutting of the topics has to be done at the moment. Thank you so much for your patience.